Committee Room 20.
Meeting open to the public. Just to advise members, the committee meeting will be recorded and broadcast throughout Parliament buildings and online. Also, anybody in the public gallery are very welcome. Mobile devices need to be in silent airplane mode, and the Wi-Fi can be used subject to the rules. So we have no apologies. We have a few members just have texted to say they're running late. Anybody aware of any apologies? No? Okay. Chair's business. So just to inform you all that I met along with Danny, the Chief Executive of the RQAA, on Tuesday to discuss the work of the RQAA, and Nuala was there as well actually, and obviously the clerk. So if you're content, committee, can we write to the department just to request further information on whether it is intended to bring forward legislation or regulations to update the role and remit of RQAA, and or to put in place a cost recovery model? These are a couple of issues that they raise. So is everybody content that we do that? Yep. Okay, just also to inform you that there is myself and the Deputy Chair are having an introductory meeting with the new interim permanent secretary of the department on Monday, and we'll update you on that as well. And yes.
So can we ask when the new perm sec is coming to meet the committee?
Well, that will be one of the things we will ask on Monday. I mean, I don't think we have any information on that yet. No. So that will definitely be one of the things that we will ask, and we'll update.
I think that's really important.
Absolutely.
That we get a sense of who he is, what he intends to do, what action and change we're going to see.
Especially if he's only on for a year.
I forgot about that actually.
So there can be no time for delay.
No time
like
to hash about.
No,
yeah.
That's it. So, and then just one other thing that not related to a meeting, but I just wanted to raise it, as I'm sure the rest of you will have been getting correspondence from our independent health sector. I know I've had a few contacts, particularly from GPs, now that the Westminster imposed national insurance contributions are beginning to bite. So I've been contacted by a number of GP practices just to say that, this is going to have an impact of, I think it's probably about 20,000 will be the average impact on the average GP surgery, and a number of them are considering or even implementing half-day closures to compensate for that. So, I mean, that's obviously an impact that's been described to me. There's obviously been media on this issue this week in relation to dentists and community pharmacies. So it's obviously going to have an impact in relation to that. So the budget has been agreed. There's 3.5 million has been allocated. I mean, is the committee happy that we maybe write to the Minister, asking how that 3.5 million, the detail of how that's going to be spent, mitigating this, and secondly, if the department have any kind of impact assessment of how this is going to impact particularly primary care, community pharmacies, GP services, dental practices, etc., in terms of the service that they provide. I mean, if every GP practice is having to make a decision about whether they don't employ staff to do work, maybe lay off staff, or alternatively half-day closures or close services, I mean, the impact to that's going to be patient care. It's certainly not going to be the Minister's policy of shifting left. So, I mean, I think the department should be able to provide us with some kind of assessment of the impact on primary care and patient outcomes, if people are happy that we write to them and ask those questions. Okay, Danny?
Certainly the last time the Minister was in, I remember you asked him directly, we named 4 of the community sector: GPs, community pharmacy, dentists and hospice providers.
Absolutely.
I think were
independent palliative care.
Independent providers, and he reaffirmed his support for meeting the cost of the national insurance contribution, the rise in national insurance contributions. 3.5 million allocated against the £36 million cost. It's nowhere near what's needed, so I think we need to find out a bit more certainty about that and how that's going to be met, because if GPs are going to be closing for half days and dentists and everybody else, less service provided. You know. So, yeah, absolutely agree.
You know, we've all sympathy with the Minister. This is imposed upon all of us from Westminster, and he has a constrained budget, but you know, it's the health outcome impact that I'm concerned about in relation to it. So, okay, everybody's happy with that. Draft minutes then, item number 3. Can I refer members to the draft minutes of the meeting held on 3rd of April 2025, page 6. Are members content with the minutes drafted and agreed them? Yep. Okay, matters arising? None? Okay, so item number 5 then, so briefing from Foyle Hospice. So we're having an oral briefing on our inquiry into access to palliative care. Just to refer everybody to tab 5 of our pack. This includes clerk's memo, Foyle Hospice written submission to the committee's call for evidence, correspondence from the hospice sector in respect of the committee's inquiry, and summary of organisational responses. So can I welcome Donald Henderson, who's the Chief Executive, Angela McIntyre, Chairperson. I have also Anne-Marie is here. Anne-Marie Casey, Director of Nursing and Clinical Care, and Dr. Paul McIver, Medical Director. So thank you very much for coming. Can I just begin by apologising? On the day of the visit, the committee visit, I think it was the second day that I was in this role, and I just had other diary commitments, so I wasn't able to attend, so apologies for that. So I'm going to hand over to yourselves if you just want to make some introductory remarks, and then we'll open up for questions.
Perfect. Angela's just joining us now.
Fair enough.
Okay. Thank you very much to the Chair, Vice Chair and members of this committee. So good afternoon, and first of all we'd just like to thank you for affording us the opportunity to contribute to this important inquiry into the delivery of palliative care services in Northern Ireland. And I suppose just really important for us to say that Foyle Hospice this year celebrates its 40th anniversary. So as an organisation we have been providing hospice and palliative care to patients since 1985, as well as offering support to their families and their carers. Therefore, we warmly welcome the work of the Health Committee to ensure that service provision is fit for purpose moving forward, and it meets the needs of those in our community who are living with terminal illness. As an independent hospice, along with colleagues in other hospices across Northern Ireland, we know that we do help to alleviate some of the pressures faced by the health service in general. But Foyle Hospice are primarily, our area of operation is in the Western Health and Social Care Trust area. We deliver our inpatient, day therapy and community services, as well as a 24/7 telephone advice line and bereavement support for both children and adults. We currently employ 102 members of staff, and they are supported by 152 volunteers across a range of activities to further enhance our services. We believe that the Programme for Government's inclusion of death, dying and bereavement recognises the importance and the value of such services. We would therefore highlight the need to focus on how palliative care services are delivered geographically, so that people have equitable access to consistently high quality of palliative care service as they need it and when they need it, irrespective of whether they live in the most densely populated postcode or the most isolated rural location. And again, to point out, for some people, their local hospital or hospice is approximately 40 miles of a journey for them. Northern Ireland has not had a palliative care strategy since 2015, as you'll know, and despite an undertaking a number of years ago to complete a review, that hasn't happened to date. So again, another reason for welcoming this inquiry. The significant delay, however, means that service providers are not adequately resourced to meet the need and or deliver the care in the right place or at the right time. And I suppose if we have learned anything from the pandemic, it is how the delivery of hospice and palliative care has evolved, and how it's much wider than just being provided in a physical building, and it is specifically tailored towards that individualised holistic care. Since 2018-19, the number of patients we are treating in their own homes has increased by 24%, and 327 of our patients who are being cared for at home have required the support of our community team at weekends. And in many cases, that weekend service has been crucial in preventing a hospital admission, an ambulance call-out, or an A&E visit. although this is a pilot project, the weekend service, it's funded by non-recurrent monies, but the uptake of that service has been significant. Within the context of Northern Ireland, we believe that we need to see a more streamlined and cohesive model of palliative care, one that supports an increasingly ageing population with complex symptoms and comorbidities. And what we must also take account of is the growth in the number of younger people that are presenting to us, having been diagnosed with a terminal illness. For example, over the last 3 years, the number of patients at Foyle Hospice aged 55 or younger has increased by 17%. I'd earlier mentioned about the non-recurrent grant funding for our weekend community service, and that sits with some other projects that we run as well. However, hospices are not sustainable with the current funding model. Statutory funding for our core services equates to approximately 40% of our total running costs for core services. The annual uplifts to our contracts do not keep in line with inflation or cost of living, nor do they offer any encouragement for us to recruit and retain suitable specialist staff that we need to sustain and deliver our services in the longer term. Looking at our closest neighbours who have been awarded funding 100% core service costs, £100 million of capital funding, and just today £5.5 million for improvement of palliative care services in the Republic of Ireland, England and Wales respectively. Since 2019, our annual running costs at Foyle Hospice have increased by £900,000 despite our best efforts to keep costs to a minimum. We rely heavily on voluntary income and charitable donations of approximately £1.8 million to bridge the gap between our statutory income and our total costs. So with a substantial deficit projected for 2025-26, that is also without enhancing or introducing any new services. Just to sum up, overall, we at Foyle Hospice, along with colleagues in other hospices, want to see the future of palliative care services as something that can be delivered collaboratively and, most importantly, in the best interests of patients, their families and their carers. Thank you very much.
Okay, thank you. So, first of all, happy anniversary and your 40th anniversary. Not surprising because it's been a recurrent theme, the 100% funding. So you're saying your funding really is only doing 40% of your core services at the minute. So if you were to get 100% funding for the core services, allowing fundraising to do other stuff, what would be the impact on the services that you can provide?
Well, the impact would be that I suppose that we would know that the service is more sustainable because year on year at the moment we're planning 1 year budgets at a time, and I think we would really, as an organisation, like to move to 3 to 5 year planning cycles, because it just means that you can plan ahead, you can plan forward, whereas when you're working on 12-month sort of, and I suppose for the most part, you know that level of funding is more or less secure, but I suppose nothing certain. So I suppose for us it would be just about planning forward in terms of our workforce, and also in terms of our bed spaces, because again, as an organisation, what we're finding is that we are now admitting the patients who are more ill and more likely more complex, closer to end of life, whereas probably pre-pandemic we would have been able to support respite for families and patients, and I don't think we're seeing as much of that coming through now as we would like to. So again, and I suppose that what we would see is that if we had that funding for core services, then we could look at enhancing and improving services and introducing new services, and it maybe wouldn't be as big a burden for us to continue to provide that weekend cover as well, if we knew that our core services was supported.
Maybe to comment on that, Donal, just to mention, I suppose, you could, I suppose, as Donal says, it's about consolidating those services, our inpatient unit and our home care service. I suppose over the past few years we've been using sort of grant monies and monies we've got just for a couple of years, and we've developed services. We have a service of specialty doctors in our home care team over the past couple of years, and they've really improved that service. We've had an outpatient service at Foyle Hospice for the past 10 years. Again, that was on year money, and so you usually live 1 year to the next to see, and I suppose that's really hard in retention of staff and recruiting staff as well. But you start those services off. Like specialty doc, we have our weekend cover now with the community team, so they're covering weekends. It's a 7-day service. Again, that money's probably for a couple of years or so. So those services are always in doubt. You can't sort of. So those, I suppose, if we had that 100% funding, I could imagine we could develop those services and be sure that they're and be able to recruit and retain staff and roll those services out across the whole trust area.
Okay. And then also in your introduction you talked quite rightly about the inequality of service or inequity of service, and the fact that people should have the same service whether they're urban or rural. So I mean, is it just resources, or is there what other changes could be made to ensure that is the same, so that people living rurally get the same access to service?
I think there's a couple of factors that affect that for us. I think particularly in the southern sector of the Western Trust, where geographically it's quite spread out. So we have a very small team, and just in terms of the number of visits that they can undertake in a day, can be maybe a little less than the staff in the urban area, because maybe the access to public transport, even for the patients or the staff, and even just in terms of the the infrastructure, the road networks, that just can make the journeys longer for some of our staff to go and visit patients in their homes in particular. Maybe Anne-Marie might be able to elaborate a wee bit more on that.
Yeah, the staff would want to be doing more visits, but they are limited by where the person is in the distance, so again, it's having that equity. You might have someone that's 2 miles from their base that they could see maybe while they're out in calls and on the way back again, but someone that's living more rurally, they might only get 1 visit a week because of you're trying to work up what's best, so it's not an equal service, and then the staff feel it, they're letting down those other patients because they just don't live in the right postcode area.
And I suppose that there's both a quantitative and qualitative aspect to it, because you're trying to maybe see a certain number of patients in a day, but in order to make sure that you get through all those visits, you're taking trying to condense the time that you're spending with them when they maybe need a little bit more time.
Fair enough. I'm just going to move around the room now. Alan?
Thanks, Chair, and it is really good to see you again. Thank you for coming and thank you for everything that you do. I just want to talk a little bit about the funding model, and you touched upon that in your initial contribution. What is the shortfall going forward?
So for the financial year that we're just in now, it's 1.8 million for this year, and we are looking at a deficit of approximately 700,000. Now, in saying that, we're very conscious of how we budget as well. So we do always try and, we've had a better year than we expected in the last financial year, but we're usually very conservative, because with all of your voluntary income and your charitable donations, it's so unpredictable that we will take into account, we'll factor in like a worst case scenario, and we're always hopeful that it won't be as bad as we maybe expect it to be, but there's just so many variables with the voluntary income.
Tell us, Donald, if the funding model doesn't change, tell us some of the outcomes that you predict.
Well, I think we would be at risk of having to look at our services, and it's sometimes a case of which service would we look at first in terms of, and we would have to be looking at throughput, but the impact would be the patients and the families that would suffer ultimately. And I suppose for us as well, if we got to a situation where we weren't able to balance the books, it's the level of trust from the community as well, because if the community are seeing that we're not able to sort of make ends meet, then are they going to continue to support us in that way with the donations and the fundraisers and the activities and the events?
Can you tell us a little as well about Encompass? Do you feel that you've been left behind, given the rollout of Encompass across the province?
Yeah, it's been a long, and Paul probably has a better handle on Encompass than me, but it's I mean, Encompass predates me. I started at the hospice in 2014, and I know that there's been a push to get IT systems in place and electronic care records from well before that. And I think there was a couple of times where we thought we were going to get across the line with different types of IT systems, but I do think that again, that's back to that sort of collaborative and working together and making sure that everything's streamlined so that we have access to the information about patients that we would need. And Paul would maybe
I agree with that, Donald. Just it's that integration of kind of, and having our hospice services more integrated with I suppose the mainline services, for want of a better word, and making palliative care services a core service. We're all seeing the same patients. We're seeing the trust patients there, so having equal access to the IT systems and even things like their training sessions and things like that would really be helpful. So I suppose an example is, I suppose, Encompass is going live in the Western Trust in May, but there's no word of when the hospices are going to actually be part of that. And so I suppose we do have access. We have read-only access to Encompass through Epic, but I don't know how things are going to turn out, but you do worry about that flow of information, and the communication is so important. I suppose across the whole health service, but particularly in palliative care, that that we're sharing that communication and information across all the different services involved in a patient's journey, really. And I suppose it comes down to that kind of fragmentation that we do see across the region in delivery of palliative care services in general, and how from one area to the next they can vary. And so it's really important that we try to bring all that together, and maybe even have for instance, a palliative care directory of services or something like that there that we can share out, so that, because it makes it difficult for any person that can be a barrier to access, I suppose, when a person doesn't know who should be contacting, and then when they do make contact and they've made that initial health professional, they want to be sure that their information's being shared to where it needs to go, and to other health professionals. And that's sometimes, and when that doesn't happen, it can be very disappointing, and it can be a very bad outcome even for that patient.
I'm conscious there's a number of contributors here today, but thank you, we value it.
Thanks, Alan. Danny?
Thank you, Chair. And thanks again for the visit. It was myself and Alan went up, and it was really informative, and certainly, it was great to see your place. We learned a lot, and it's a lovely environment. It really is. I was really impressed by the weekend service, and certainly, as you mentioned, Donald, the impact that would have on statutory services. So less GP call out, less visits to A&E, less calls to NIAS. Is there any way to quantify that? Have you been able to?
Yeah, well, the staff of a weekend, they have for every visit that they do, they have to provide stats then to say, if they hadn't been there, what would happen. So we have a table, and it's if it's on in regards to medication, then they provide symptom management. So then at the end of every month, we would tally that up. So we have to provide statistics to the funders to say too that what they got for their money. So they do, but we also find as well, it's not even for the patient. The district nurse, the key worker in palliative care, and the district nurse are finding it such a helpful service at the weekend, because they could have been stuck with the one patient all day, whereas now with our nurses out, they can do a joint visit, so they know what's happening and they're not doubling up in time. And it's actually, we have a nurse prescriber as well, so she can actually change the syringe driver chart, have it there for the district nurse, rather than before what would happen, the district nurse would have to go to out of hours, get that chart, bring it back. If there was a prescription, then the family have to leave their loved one to go and get. So it's actually making it easier for the patient, so that they're having quality time, which is quite, we don't know how long they have. So if you spend 3 hours on a Saturday trying to get a syringe driver sorted, and you come home and then your loved one passes away, you've missed out in them 3 hours. So we are gathering the data, and again, we're even trying now to see if our nurses hadn't been on duty, that would have been a hospital admission and what would that cost. But also we can actually plan admissions now to the hospice for a Monday, whereas before, if the nurses weren't on, you know, you were looking at your referrals on a Monday, and because you hadn't had an update over the weekend, you know, it could be maybe Tuesday or Wednesday before a patient gets admitted, but by that stage then they're too ill to transfer and they miss out on that, what their wish was, maybe to die in the hospice.
No, I can absolutely see how that would have multiple benefits, you know, right across the system and complement the statutory services. And in many cases, as you say, step in before statutory services needed. So you're avoiding those inappropriate admissions to hospital, ambulance pressure in the ambulance system, A&E and GPs. So it'd be very, very interesting to see, you know, the impact, the quantification of that. That would be great. One of the things that's come out regularly that we hear is that the public have their own perception of palliative care generally. What do you think the department needs to do to sort of educate the public on the benefits of palliative care?
Yeah, I suppose, you know, there's, as you say, a general lack of awareness. So an educational program, I guess, you know, I suppose if we had a strategy, you know, coming back to that, you know, with an educational component to it, that we could, that would raise awareness. You know, there's a lot of negative connotations, and people think that palliative care is just about the end of life, or even just for cancer patients. So all that needs to be addressed, and you know, and of course there's the advanced care planning policy and the respect document, things like that are we know we're sitting in and are ready to go, I think, and just need to be rolled out, but backed up by an education program. I think that would be, you know, that would go a long way to sort of increasing that awareness, really, in general. And I guess not just a palliative care issue. That's for everyone. That you know, advanced care planning policy and respect document and general education.
Yeah, and I think just to expand a bit on that, we deliver the Compassionate Communities Northern Ireland model at the minute, which is linked into the public health approach to palliative care. So that's kind of a more community focused and a very a look at death, dying and bereavement as well, with across the community, and not just for those who have a terminal illness, but again around the advanced care planning and things like that. But something that we did look at a number of years ago was about having a resource which was an education officer to sort of look at engaging with nursing homes, community groups, local schools, local businesses, all of that. But it's just not affordable at this point in time. We did look at it over a number of years. I think what we find at the minute, a lot of the education and the awareness raising, you know, we would link in with the All Ireland Institute around Palliative Care Week, and we would link in with Hospice UK around Hospice Week as well. So we try and use those as opportunities to sort of increase awareness among the general public. But it's certainly something, and I think as well, one of the things that our fundraising team would do is when they're going out into the community, they will give little presentations or talks, and they'll maybe take one of the healthcare team, one of the nurses or one of the medical team with them, just to sort of provide a bit of insight as to what we do in the organisation. So that's, you know, it's very limited and it's very ad hoc, but something a bit more structured would definitely, and whether that's in each organisation or across the board, you know, that would be really helpful, I think.
One last thing, one of the things that you talked about previously was the bereavement service that you offer, bereavement counselling.
Yeah.
For children and for adults.
Yeah.
Could you give us a bit more detail on that?
So we have what's called our Healing Hearts Children's Bereavement Service, and that's for children up to the age of 18, and that's irrespective of the cause of death. So it potentially would be children who have been familiar to us through our services, but it could be children who've been impacted as a result of a road traffic collision, suicide, sudden death of a significant adult in their life. And that at the moment is 100% funded through our voluntary income and charitable donations. We do have a small amount of funding through the Cancer Charities Relief Fund as well to enable us to have an additional counsellor, because the demand for that service is significant. And then the adult counselling service, that's on a referral basis, and that's time bound as well up until July or September. but we've had to close. We had a waiting list for that, and we had to close it because the demand for that service has been absolutely phenomenal. But that is time bound. Prior to getting the funding for that, we have a number of volunteer counsellors who have provided service beforehand. We're hopeful that when this money runs out that we might still have access to those volunteer counsellors, but it's the uncertainty around that as well that makes it just a little bit more difficult to plan ahead.
Amazing services to deliver.
Thank you.
Thank you.
Thanks, Danny. Diane?
Thank you, Chair, and thank you again, like everyone. We are in awe at times of the service you provide to people at their most vulnerable in their life. Just going back to your funding allocation, and maybe help me understand that. Is there a general formula for funding allocations to hospice for those core services, and how is that worked out? And is it the same for all hospice services?
I don't think there's an actual sort of formula. I know that we just get a block grant, if you like, a certain amount of money now.
How do they work? But how do they calculate that Foyle gets this, the Northern Ireland Hospice gets that, the Southern Hospice gets something? It's just, I don't think in any of the conversations we've had we've understood, and maybe I'm wrong, but I certainly haven't understood it.
I do think whenever we're asked for some of the information, we're usually I think there is a calculation loosely tied into the number of beds and the bed occupancy. Looking at the statistics around that, and I know that we have asked a number of times. We've asked the commissioners for a breakdown of how that money is carved out for our day hospice, for our community, and our inpatient unit, and we've never really got to grips with how much we're getting for each. So it's very difficult for me to say to you exactly what we're getting and what it's for, But all we know that is it's a pot of money, and it's to deliver these services.
It's quite remarkable. It is actually quite remarkable, and maybe that is a question for the committee to take up, because certainly I haven't heard it articulated in that way before, and that's why these evidence sessions are absolutely invaluable, because we want to make sure that everybody is getting what is appropriate to the region that they serve and what serves the needs of communities within that region. But if we don't understand how it's allocated and on what basis it's allocated, that's an entirely different set of circumstances that we find ourselves in. So that's perhaps something that would be very good to know. Everybody in this committee knows that I ask the same question every time, because I am really quite keen that we see hospice services and palliative care as a core part of our health service. How would that change things for you?
In terms of what, sorry?
Well, in terms of, I sometimes think that palliative care, we don't leave giving birth to charity, but we do leave palliative care partly to charity. So how would it seen as a legal requirement from the department to commission the required need in terms of palliative care? How would that change things for you? It's very hard to see how it would look, but I do think what we would not want to lose is that we wouldn't want to ever lose that high quality, individualized, holistic care. We would be very. I think colleagues in the other hospitals would be very clear about that. Is that it would not be, and this is no disrespect to anyone who's working in the sector, but it wouldn't be just about the number. It's not always about the number crunching for us, because we need to make sure that the patients are getting the right care in the right place at the right time. So I suppose that's one of the risks that we would be very keen to see that would be mitigated. And obviously I would expect there would be some further level of control if there was more significant funding for hospices.
but obviously we are regulated by RQIA as well. So, you know, I would hope that there would be little, if any, changes with that in that regard, because we are quite strictly regulated through that channel as it is. But I think the one thing that we would be very clear about is that we would want to make sure that the service remains holistic and individualised, and gives the patients a level of choice as to where they choose to die.
Yeah, no, I think that's very important. Your weekend service, I apologise, I didn't get up to see the hospice, and I do think that this is a great service. So to access the weekend service, you have to be a patient or have been referred to the hospice. Yeah, that's correct?
Yeah, but the nurses, even if the patients aren't known to the team and a district nurse rings in looking for advice on that patient, the nurse will give the district nurse advice to go on. So the district nurse can go to the GP out of hours and say, I've spoken to the hospice team, and this is what they suggest. So it's kind of...
So you've anticipated my next question. It really was. Because it does sound like a service that could be expanded, that would really be beneficial for people. I think one of the things that we would all like to see is less patients who have palliative care in accident and emergency situations. So I think that would be beneficial for everyone involved. And I think that it sounds like a model that if you had some contact with GPs, etc., that could be expanded and worked upon to actually make that broader and wider.
We only have one nurse at the minute that covers the weekend. So in our northern sector, like they're covering Derry, Lumabally, Strabane, Claudy. So it's a big area. Yes. So for one person to try and maybe go to Ballerina, and then there's someone in Clary and Strabane looking for, you know, and that nurse is like in a whole quandary. So if you had two nurses, you could have them going on different bases so that it's not, you know, who's nearest or who's most in need, and they can link in. But I think too with the weekend service, it does give the district nurses a bit of backup as well, that we can say to them, look, if you go to this patient today and sort them out, this is the advice, and then I'll follow up tomorrow. But if we had more members on the ground, I think it would make a lot of difference for patients, because, you know, we could have what we do on a Friday is we would make a list of who the patients are that you think will need the support at the weekend. Yeah. But you could have 10 on that list, say, and then there could be 3 people that you didn't think anything was going to happen to. Yes. They suddenly deteriorate, and then that changes the whole mindset. So, you know, if you had another person on the ground as well, it would make a difference.
So would that could you join that up with, for example, that outpatient service?
The outpatient service is only during the week.
But is there potential with more funding, more GPs involved, etc., that you could provide that outpatient service at the hospice? Is that I think one of the things we'd all like to see is less patients being traumatised with ED, and I think we do have to sort of find some recommendations around that try to help us. And I think that kind of the outpatient service, the weekend service, that kind of thing is where it's going to be at, isn't it, really?
And even our 24/7 helpline, you know, our doctor is on the inpatient unit at the weekend, but they're getting calls from different people as well, you know, from other GPs that maybe haven't known that patient, or from even the hospital sometime, you know what I mean, if they're worrying about a query in regards to symptom management. So our line's there, but again, you know, that line is in the inpatient unit, and the staff in the inpatient unit are trying to look after the 9 patients and give them their time, as well as maybe take advice calls. And, you know, patients are traumatised when they're ringing, or their relatives. They just want someone to help them. And maybe if they're being told, look, wait 10 minutes and I'll get back to you, that 10 minutes can seem like 2 hours. You know, and it's knock-on effects. So again, you know, with the advice line, the doctors can maybe take a call and, you know, give advice, or the patients are very appreciative even if a call back and just someone to listen, because they'll be ringing out of hours and it could be 6 hours before someone's getting back to them, whereas we would get back to them kind of within a half an hour at the most.
I think it's invaluable. It really is, and I think that there's some really practical things that the committee can think about from your presentation today. So thank you very much. Thank you. Really appreciate that. Thank you.
Can I just say something?
Of course you can.
Absolutely wonderful. Everyone, and some maybe not as much as others, but they're all wonderful.
Thank you very much. Linda?
Thank you, Chair, and thank you to all of you for your presentation. And I mean, a lot of what I was going to ask has been covered, because Diane's right. I think that it's vitally important that people are not ending up in A&Es when they're palliative care patients. And I mean, you have already outlined this, you know better than anybody else, that particularly when we're getting to the end of life, and every minute, never mind every hour, counts. It's so valuable, it's so important, and not to have people traumatise families and the individual themselves traumatised in the middle of that is so important. So just a quick question. You talked about what you couldn't do if if you didn't have the money. I suppose what I want to get an understanding, and it's kind of where other members have sort of took us a wee bit of the way too, is if you were 100% funded, so say your inpatient beds were 100% funded and commissioned and funded, then what additional could you do? Because you talked about the therapeutic services and stuff like that, and that's vitally important. I mean, if we were able to get more of that, you've actually talked about some of the stuff that you could do more of. So it's just getting a sense of what could you do if you had that help. So I'm thinking particularly of the when St. Francis Hospice was in front of us, that was kind of some of the stuff they were saying, because they're 100% funded, they can do so much additional stuff because they still fundraise. They didn't stop fundraising, they didn't stop providing the other services. But it meant that they could do so much more in terms of that stuff, because they still do the fundraising and they don't have to worry about the running cost of the hospice. Because that's covered, and they can then provide additional services. So we're supposed to get a sense of is there more that we could do if you were getting more funding from the department?
I suppose, Linda, I think we've mentioned some of those things. I suppose if we got that core kind of funding, then the weekend service we've just been talking about, that's time limited. That's on grant funded money. Our outpatient service that we have there is time limited, and so that runs from 1 year to the next. Our counselling service, again, runs from 1 year to the next, and we've said already that actually the counselling service, it's such a huge demand, we've had to close to new referrals, but that will actually be coming to an end in 2 or 3 months' time. So where's all that demand going to go? So if we felt we had our services funded, then obviously the money then that would be coming in from the fundraising we could put to those other services and make them more sustainable and develop them and increase them, and I suppose the effect, as Dan was saying, would be to keep people in their own homes where they want to be, and care for them there, so they don't, but what's going to happen in a couple of years if that funding for the weekend service runs out? That we'll just be back to square one again, and that's been the nature, I suppose, of palliative care kind of services over the past, really since their inception. There's been great innovation. Hospices are very agile and can change things, very quickly, and come up with great ideas. But what we find is, you get a service set up for a year or two, and then the funding disappears, and that's very disheartening for everyone. So, yeah, it's about developing the services that we have, sustaining them, and also by doing that we can attract, staff in as well. Who, that's another issue that we have in the West as well as the recruitment and retention of staff. So that would be, if we had sustainable funding like that, we could recruit we have great staff already, but it's keeping them. So that it's all part of it. It's all. I think if we did make palliative care a core service and it was funded as everyone has a right to palliative care as such, then instead of people having to actually. And what is happening, actually, they're paying for their own care, really, when they're receiving palliative care in many aspects. So, and that doesn't happen with any other part of the service, really, does it? If you're not paying for your own, maybe GP or cardiac services or whatever. So, it's coming down to fairness and equity.
And maybe just to add to that as well, there's currently SPPG had undertaken a review of the day hospice model or day therapy services, and I think there is an expectation, and we understand that expectation, we understand why, is that there will be more of a focus on sort of clinical services. But I suppose that the really important thing about our day hospice service, for those patients that are coming through, we provide some complementary therapies as well for them. But for those patients coming through, it might be the only time that they'll get an opportunity to meet people who are in the same situation as themselves. And I think whilst the clinical side of it is really important, there is a social aspect to it as well, and I don't think we can lose that in its entirety, because I think it's really important for those people to meet people like themselves who are going through the same process, going through the same emotions, and sort of form their own little sort of support network, because no one knows how they feel as much as themselves, and I think that's something that we would, that's the kind of thing as well we would like to, that sort of health and well-being, and would be really something that we could develop more as well. Yeah.
That's perfect, Chair. Thank you, and again, thank you to all of you, and other members have already said it. Ourselves, but as a wider community, it is much appreciated, and palliative services would not have been there for so many families if it weren't for the charities that are out there in the hospices and doing the fundraising. So it is very, very much appreciated. Thank you.
Thanks, Linda. Alan?
Thanks very much, Chair. Apologise, I wasn't able to get to the visit to your hospice, but certainly heard great reports coming back from that visit. And I know that the reputation of your hospice is admired well beyond the Foyle area. So I appreciate and thank you for that. You talked about the 1.8 million shortfall this year. Is that before the charity donations are taken into account, or is that a projected shortfall even with charitable donations?
So just to clarify, that's what we need to make up. That's what our fundraising efforts, if you like, that's what we have to raise through our fundraising efforts. But even with trying to raise that amount of money, we would still potentially be looking at a 600-700 deficit. But that's what we aim to raise within the current financial year to make to balance the books.
Yeah. In terms of, are you under an obligation to balance your books each year, or do you have the facility to carry forward a shortfall? I'm not advocating that you should, but
I understand.
Do you have to to balance the books?
Well, no, that's really a decision, and Angela's probably a better placed than me to speak about that. But that's something that we would take through our Finance and Audit Committee, and subsequently to our Board of Trustees, and I suppose then it's really up to us as a senior management team. So Paul, myself, Anne-Marie, and two other colleagues, Sheila and Terry. So we would make sure that we've done all our homework beforehand to see where we potentially can cut costs, where we can identify ways to raise more funds through those short-term grants and things like that, and then presented to Finance and Audit Committee before it goes to full board and they will they'll look at it, and then I suppose it's really up to the board at the end of the day whether they'll accept that deficit budget or not.
You see, we talked about the variables, because you don't know how much you're going to bring in charitable donations. Would there ever be a sort of a situation as the financial year progressed where you'd face almost a doomsday situation where you may have to suddenly stop a service just in the interest of trying to balance the books by the end of the financial year?
Thankfully we haven't had that to date, but I think as well we have quite a robust financial management programme within the organisation. So our Finance and Audit Committee meet every third quarter, and they will have a quarterly report. So we would probably be able to sort of plan for the next 3 to 6 months, and I suppose we would be looking at what our income is. Are we on target? Are we raising what we said we were going to raise with our fundraising? Is there a shortfall? And is that likely to sort of continue over the year? And then I suppose that's something where we would have to then look at our services. I suppose an example is maybe a loose example, but we have an integrative care clinic, and that's, Paul mentioned it earlier, that
it's really our outpatient clinic.
It's the outpatient clinic, and that's been running for the last 10 years. So whilst that money's not been taken away from us now in the current financial year, the money has not been allocated for the purposes of running an integrative care clinic. So we have had to look at winding that clinic down and look at what way that money then can be utilised to support our community services in a different way. So I suppose that's one of the things that we had in the last couple of months, the last couple of weeks, that we've had to say, well, actually, but we're looking at we're trying to put mechanisms in place so those patients won't be left high and dry, that we will be able to refer them to some of our other services or signpost them to appropriate services outside of ourselves.
Certainly, I mean, you talked there about a 3-year budget or even a 5-year budget, so much better situation to be in. And it would allow you to create new services with a degree of confidence and assurance and recruitment of staff. And I'm sure that, it's hard to recruit new staff on a 1-year contract.
Yeah.
You can't give them any guarantee beyond that. Has there ever been any, proposed new services that you've come up with or you've seen somewhere else that you thought you could use? Have you ever had a situation where you've had to, that's a great idea, but you've had to put it into cold storage simply because the 1-year budget is holding you back? Yeah,
well, I mean, probably the one example that comes to mind, and I suppose there's a recurrent cost to it, but it would be a capital cost initially, is I'd mentioned earlier about we're not just able to provide the respite, the level of respite care in our inpatient unit that we would have done before, I suppose pre-pandemic really. But we would like to be able to provide that again, but that would require building on between 2 and 4 additional bed spaces. Now that's not necessarily that we would commission all of those bed spaces at the one time, but economies of scale would suggest that it's cheaper to build 4 rooms than it is to build 2. So there would be obviously then a recurrent cost in terms of staffing to support those bed spaces. So that's something that we've had it in our strategic plan, and we've had to carry it forward now for I think the second time. And we just don't feel confident enough that we would be able to raise that additional. I think the capital would be okay, because again, I think there would be a huge fundraising campaign around that, and I think people like to sort of, there's a capacity to donate to something that's tangible and you can see it. But I think then it would be the day-to-day running costs of it where we would struggle, and we would be concerned that that might be a bridge too far for us at the moment.
That must be frustrating for you. Well, listen, thank you very much for all that you do.
Thank you.
Thanks, Alan. Nuala?
Thank you, Chair. And thank you very much for your presentation. First of all, sorry that I was late. I just was at a police board committee, so it ran quite on. I don't have any questions specific to yourselves. I just wanted to thank you for your presentation. It is particularly helpful for MLAs such as myself from more an urban setting to actually get a bit of the reflection and the difficulties for those palliative care organisations that do work in the rural communities. So it was helpful for me in that context as well. And I just wanted to say thank you for that.
Thank you.
Okay, thanks, Nuala. Folks, that's been very, very useful. I really appreciate you coming before us and giving your expertise and your evidence, and obviously participating in our inquiry. So keep up the good work, and hopefully our inquiry report will do you all justice.
Lovely, thank you.
Thank you very much.
Thank you. Okay, members, just moving on. So next item is a briefing from RCN and RSP CNG. So again, oral briefing on our inquiry, access to palliative care services. Can I refer everybody to tab 6? So there's clerk's memo, there's written submission, there's evidence from the RCN, and written submission from RSCNG as well. We also have the Life and Times Nursing Agency's written submission to your evidence call, and then there's summary of responses from nursing health professionals at page 197. So can I welcome Karen Bowes, hope I pronounced that properly, Senior Nurse within the RCN, Ruth Thompson, Associate Director, RCN, Bernie Torley, Advanced Nurse Practitioner, Training Nurse and Manager within the Southern Area Hospice, and Denise Cranston, Specialist Palliative Care Lead Nurse within the South East Trust. So you're very welcome, and thank you very much for coming. So As always, I'm going to give you a couple of minutes just to make some brief introductory remarks, and then we're going to take questions. So,
I'm going to make a start, if that's all right. Thank you. So the RCN would like to thank the committee for the invitation to come today and welcomes the opportunity to supplement our written submission with oral evidence. Nurses play a unique and critical role in providing palliative and end-of-life care. Our skills, compassion and ability to offer continuous support are central to ensuring that patients and those important to them experience a dignified, comfortable and peaceful end-of-life journey. Palliative and end-of-life care is provided by nursing staff who work across hospitals, in the community and in the independent sector. Nurses deliver this care within the generalist nursing workforce and then also through the specialist palliative care nursing workforce. The RCN is delighted to attend this session today along with the Regional Specialist Palliative Care Nursing Group, who will expertly represent the specialist palliative care workforce across Northern Ireland. So this enables us, Karen and myself, as the representing RCN, to give an overview of the impact generalist nursing staff make in palliative and end-of-life care provision. So within RCN Northern Ireland, we have an active palliative care member network. So we've engaged with our network members to inform our response to the committee on the current palliative care nursing provision across Northern Ireland. The network is a diverse group of nursing staff from district nursing, care homes, hospices, specialist palliative care teams, education providers, emergency departments and GP surgeries. So the diversity of this membership gives an indication of how wide-reaching palliative and end-of-life nursing provision is across our healthcare settings in Northern Ireland. Generalist nursing staff includes nurses working on wards, in emergency departments and in the district and in care homes. They require education and support to provide ongoing palliative and end-of-life care, particularly as specialist nursing support, as you know, is often limited out of hours. We feel a comprehensive, accessible and responsive education package is needed to maintain the training and competencies of these generalist nursing staff with access to updated education programmes. District nurses make up a significant proportion of the palliative generalist nursing workforce. The district nursing framework defines the district nurse as the key worker in palliative and end-of-life care, citing that the majority of palliative care is supported in community settings. District nurses are the healthcare professionals who see the patient most often in their home. The 24-hour palliative and end-of-life care at home provided by district nurses and available in some trust areas is invaluable and makes palliative care more accessible for patients and those important to them. The district nursing service reassures families that support is available 24 hours a day and underpins that their care is a priority. And I know you've heard before that up to 25% of their caseload can be palliative care. Disappointingly, a 24-hour district nursing service is only available currently in 2 of our trusts. Nursing staff in the care home sector also make up a significant portion of the generalist palliative care workforce. The RQIA Care Home Census Report in 2023 indicated that there were over 10,500 nursing home beds across Northern Ireland. Our nursing colleagues within the independent sector strive to provide a high-quality service to meet the needs of their residents, but the challenge remains to ensure that they have access to training and support to gain and maintain the skills and competencies required to deliver palliative and end-of-life care to those in their care. The RCN Northern Ireland Palliative Care Network has previously highlighted nurses' concerns regarding the delay in the implementation of the Northern Ireland For Now and For the Future Advanced Care Planning Policy, which was launched back in October 22, and the supporting recommended summary plan for emergency care and treatment, otherwise known as RESPECT. Many patients receive treatment and care across organisational boundaries and settings, so patients often have to have multiple conversations with various professions about their healthcare wishes and preferred places for receiving end-of-life care. These repeated conversations can cause emotional distress and frustration to patients and those important to them. We need to progress the implementation of advanced care planning and RESPECT. Most of the hard work has already been done, but we need to progress this as a matter of urgency, and this requires funded, resolute post holders to implement this safely. The RCN values the ongoing support that the committee has shown for nurses and nursing in Northern Ireland. Although we continue to face challenges within our services, we also feel it's important to recognise that we do have a world-class nursing workforce here in Northern Ireland, comprised of talented, highly educated and deeply committed nursing staff, delivering high-quality nursing care to the people in our society, including those requiring palliative and end-of-life care. Our nursing staff, whether they practice in the HSC, in our nursing homes, in our GP surgeries or primary care settings, make an invaluable contribution in the active, holistic care of patients with advanced progressive illness each and every day. Thank you, and I hope this introduction has been helpful.
Okay.
Thank you, Chair, for giving us the opportunity to speak on behalf of the Regional Specialist Palliative Care Nursing Group. Nursing is the largest workforce involved in the delivery of both generalist and specialist palliative care. You've already heard from our RCN colleagues about the significant contribution nursing makes to generalist palliative care, and we welcome this opportunity to highlight the work that specialist palliative care nurses do and some of the challenges we face. A specialist palliative care nurse is a registered nurse with advanced specialist knowledge and qualifications. We use a person-centred approach to holistically manage the physical, emotional, social and spiritual needs of patients with life-limiting illnesses and their families, focusing on improving quality of life. We mostly work Monday to Friday 9 to 5, delivering palliative care to our patients with the most complex needs across all care settings, so hospital wards, emergency departments, outpatient clinics, hospices, care homes and patients' own homes. Patients die at all hours of the day or night, not just Monday to Friday 9 to 5. Care needs rarely fit neatly into this 40-hour working week, leaving a large period of time designated to out of hours with no face-to-face specialist palliative care. We support, educate and empower generalist nursing staff to identify and deliver high-quality palliative care across all these care settings. As specialist nurses, we are extremely focused on the wishes, beliefs and values of our patients and their families, advocating on their behalf to ensure their wishes are respected and listened to. According to the 2024 report from Marie Curie, Public Attitudes to Death and Dying in the UK, in people's final days of life, they ranked their top 3 priorities as 1, being free of pain and other symptoms, 2, being in the company of loved ones, and 3, being able to maintain personal dignity and self-respect. As specialist palliative care nurses, our aim is to ensure that everyone in Northern Ireland with palliative care needs, regardless of their care setting, receives the highest standard of palliative and end-of-life care. However, this is challenging. The demand for palliative and end-of-life care is projected to increase over the next 20 years by 25% nationally and by 32% specifically in Northern Ireland. This increasing demand already exceeds the capacity of the specialist palliative care nursing workforce, leading to delays in patient assessments, potential waiting lists and immense pressure on staff, negatively impacting recruitment and retention. Data reviewed in 2023 revealed a 44.5% turnover rate amongst specialist palliative care nursing staff. Filling vacancies and recruiting staff with the required knowledge and skills has been challenging. This difficulty arises from the lack of dedicated training positions and lack of succession planning for specialist palliative care nursing roles. There is a disconnect between commissioning, education and succession planning. In the past 5 years, only 18 places on the specialist practice qualification course in palliative care were commissioned, compared to 33 places funded by hospice charitable funds. Currently, we have 4 AMP trainees, 3 of whom have been funded by hospice charitable funds, with only 1 commissioned. Unlike other specialties, there are no dedicated training positions in specialist palliative care nursing. There are also disparities in palliative and end-of-life care provision across Northern Ireland, especially during the out-of-hours period, leading to an increased reliance on acute and emergency services. Effective communication across sectors can also be challenging. Encompass strives to enhance communication and integration, but currently hospices are limited to read-only access. Unlike trust colleagues, specialist palliative care nurses in the hospice sector lack a process for obtaining cipher codes or prescription pads. A project at Foyle Hospice is addressing this by using the hospice cipher code to enable staff to prescribe medication during home visits. Early data shows this significantly reduces the time between prescribing and patients receiving medication, enhancing patient experience and allowing loved ones to spend more time together. We believe the solutions are both regional and local. We need to understand the population need, taking into account patient complexity and demographics, and also the current specialist palliative care workforce. This will inform planning and should include transparent, fair commissioning. We need a sustainable specialist palliative care nursing workforce equipped with the knowledge and skills to care for those requiring specialist input. This will require commissioned specialist education, including dedicated training positions, inclusive of the independent sector, and support for nurse-led research in the field of specialist palliative care. We need a clear regional career development pathway to reduce staff turnover and burnout, with investment into advanced nursing practice and nurse consultant roles within specialist palliative care. We need a clinical lead with accountability to provide strategic and influential clinical leadership. We need a new palliative and end-of-life care strategy for Northern Ireland to deliver up-to-date strategic direction and support. There is a need to establish long-term sustainable regional funding model for the independent hospice sector. Implementing the advanced care planning policy, including the respect form and process, to ensure timely DNA CPR discussions is required as a matter of urgency. We cannot overstate the moral injury and distress caused to patients, families and nurses from not having the respect policy implemented. Patients are having to have DNA CPR conversations multiple times or not at all, because there is no process or documentation to transfer decisions between care settings. All hospices in Northern Ireland need full access to Encompass urgently, as do all nursing staff delivering palliative and end-of-life care. There is a clear identified need for a single point of contact, and this will ensure people can get access to reliable, consistent palliative care information and support. Work has begun to scope and cost a 7-day working model for specialist palliative care nursing in the out-of-hours period. We await the outcome of this work, but in order for its potential to be realised, it will need to be funded and prioritised. We have the capability to deliver excellent patient-centred palliative and end-of-life care. Addressing these solutions would enable us to provide this high standard of care more consistently. Thank you.
Okay, thank you. So, I just want to say, not just for yourselves, but the quality of evidence that we've actually received from everybody that's come before us during our inquiry has been at a really high standard. I had a raft of questions, but I have to say that you asked and answered my own questions there, which is good, because we want to get to the crux of the problem. So we obviously are doing an inquiry. It will cover a lot. We'll make lots of recommendations. Hopefully it will be a good report, and hopefully then it will be implemented. But ultimately it's about delivering patient care where that needs more resource, more staff, more funding, whatever it takes. So from our point of view, or from my point of view, I suppose today the key issues facing healthcare providers in providing that ultimate excellent care, and if you could, over and above what you've already said to us, because you have been very detailed, and that's appreciative. And also in your evidence you talked about the difference and disparity among trusts. Mm-hmm. So what could we do, or what are the kind of blockages? Why are some trusts doing more? Some trusts might be doing things better, some trusts might be doing differently. So if we can just get a sense of, from your point of view, what are the disparities, because we kind of understand that, but what's the blockages that are leading to these as well? Mm-hmm. So I'm not sure how you just want to share that out.
I think that the mixed economy between the commissioning, trusts and the independent hospice sector, I think that mixed economy of commissioning plays a big part in the disparities. It's not transparent for commissioning regionally, and I think that has a massive impact on it. There's excellent work being done in different areas, but it's, I suppose, again, that lack of, we do work well together, but there's a lot more integration and better communication, a more coordinated, standardised approach, to really to look at it exactly, and I know others have quoted this, but the scoping exercise, we need to know what is out there, because there's excellent work going on and we may not just know about it, and it's that would be the key thing to me.
Yeah, and I suppose then just to add to that, I suppose for us as the leaders within specialist palliative care, some of us will have taken on quality improvement projects or initiatives, and we'll have identified a gap within our own locality, and maybe done a project, and that's where you've come about with the just in case boxes in the Western Trust. We've got rapid access hubs in the Southeastern Trust. You've got the Foyle, the nurse prescribing. So each trust, and that's probably just down to ourselves identifying a need, because we have seen the delivery of care for the patients, and we've decided, we've made that decision around how can we improve this and how can we improve it with what we've got. And so I suppose that's where some of those projects and initiatives have come from. It's just ourselves coming to our managers and saying, we think we've got a solution. Will you support us to develop this project?
Yeah, it's the lack of the regional approach, it's the lack of the standardisation. So we all do what we do because we know the impact we can make, and we know the gaps, they're glaringly obvious, and we hear it time and time again from our patients and families. And there is excellent work going on. The Southern Area Hospice have the out of hours end of life nursing project that was set up, but again there's no recurrent funding for that, so that's continued at risk. So there's excellent projects going on. Lots of different wee areas are doing projects, but because of this lack of funding and lack of resources, we can't scale it out and spread it, and it's a real shame because the work's been done. We don't need to reinvent the wheel or start from scratch. That the evaluation of the projects have been done. We see the impact it's made. We can see the difference these projects are making, but I think it's the lack of the standardised.
Yeah, and the scale and spread doesn't always have to cost money either, because sometimes these projects that are being done, it's just a new way of working or using the resources that you have. But again, there seems to be a lack of being able to just get that information and use it, and people having the ability then to be able to do that. Obviously some of them do cost money, but there's other ways in which, just by changing how you use your resources as well, like some of the projects that are ongoing at the minute are phenomenal, and just with using the resources you have, you can really make a difference. I think and nursing has really proved that, hasn't it?
Yeah, absolutely.
And
some of the initiatives that we have seen and heard about from our members have come from them identifying a need. So in ED, they're going to be taking on some palliative care nurses in ED to expedite discharges within the care home setting. Some of the trusts have inreach into care homes so that they can then support the training of syringe pumps and things like that for nurses. So it has been almost something's identified in pockets, and it hasn't been sort of then picked up regionally.
Okay, and I think, Denise, you gave a few examples of different, with regard to medicines. I mean, we have a dialogue about the potential benefits of non-medical prescribers. So, is that something that could be developed and would be beneficial?
So again, most of the trusts and both hospice will have non-medical prescribers within their specialist palliative care team, and it's something that we would advocate for and something that we would encourage within those teams. Again, it comes down to commissioning. Thankfully, it is one that has been supported over the last few years, and we have been able to get staff through that programme. I suppose going forward, and there is a change within the specialist practice qualification, that those people that would be embarking upon that programme will come out with their non-medical prescribing. So you've got two-prong approach to how you would achieve that result in having a non-medical prescriber within your team. But any of the teams that have them have actually seen the true benefit of it, because of the timely prescribing and obviously the timely changing of that prescription if it's needed. And it has been evident within obviously the piece of work the Foyle Hospice has done, and we anticipate the report of that to see that if that can be spread more widely than what it is within Foyle at the moment.
We also have prescribing happening within district nursing, so we've got the advanced nurse practitioners within district nursing, and they're able to prescribe in their 24/7 service in some areas, but again it's limited numbers. For instance, we've got one in North Belfast, one in West Belfast, and 2 are waiting to qualify in South and East. I know you heard from the divisional nurse for Belfast a few weeks ago, so that's happening in those areas as well. And equally, they can prescribe for patients at end of life as well as the specialist nurses.
Okay, and my last question, Bernie, you detailed the workforce issues very well. I was struck by what you were talking about in terms of training, and I mean, you seem to be suggesting that the majority of specialist nurses are actually being trained as a result of the fundraising as opposed to being commissioned. So can I ask a question? So again, that's because places aren't being commissioned. Is there an issue, is that the issue, that there's not enough training places? No?
Training places are available.
Okay.
They're definitely available, and it's a lack of commissioning. So over this last 3 years, they've all been hospice charitable funds that have paid for those specialist education. There's no commission places this year coming up at all.
Okay.
Which is shocking.
And from the generalist workforce, there is commissioning that comes from the department for the trust, but again, it's very small and it has been reducing as well.
That is shocking, to say the least. Okay, I'm just going to move round. Arlia, you're first.
Yeah, no, and just to follow on, so it is shocking, and I think that it was actually the point that Diane made in the last session really stuck with me, that you don't have to pay for your own birth, you know, at the stage of, you know, coming into life, into this world. The services are there, paid for by the department and the state, as they should be. So why are people in this position where they're having to fundraise when they're going out of this world? It's just really stuck with me. So I think that all the issues that you've raised, I think each of them seem to be coming back to the commissioning. So yes, it mentioned around, well, obviously the commissioning of the specialised palliative care workforce, but then obviously it's still very late in terms of the more generalist commission places. And I wanted to ask my first question around, so where does all of this fit into the department's workforce strategy? Are you feeling confident, secure in terms of how that work will be rolled out and where you and your teams fit into that? And you had also mentioned then around the training and the lack of succession planning. And my question around that is, who leads on this? So we already have the workforce strategy designed and in place. Who needs to take the leadership on these things to make sure that the succession planning, the commissioning of the appropriate number of places is all contained within this work? Who is accountable for overseeing this? Who needs to take on the leadership? And I know it was referenced in previous sessions as well around this idea of appointing a clinical lead. In your view, in your opinion, do you think that it's that person that would take on that role? And I know that there's the Palliative Care Partnership Board that's in place also, you know, because for me it's like, I think Philip's first question was around the variation across the trusts, and again coming back to the commissioning. So, you know, how we've ended up in a situation where, you know, one trust is able to provide this type of service to people and constituents, and in another trust the service mightn't be in existence. So I'm just trying to unpick, in your opinion, how have we got to where we are? Is it a leadership issue? Is it a structural issue? Is it a commissioning issue, a workforce issue? Is it all of the above? And then going forward, how do we make sure that coming out of our inquiry that we are getting the most effective, impactful recommendations to make sure that going forward we can get that consistency across all areas and get that stability for your workforce?
I think there's definitely a regional approach needed, and the clinical lead is probably someone that then could oversee, you know, what's happening. We need to scope out what's out there. I mean, the information that we give you has come from our members, so not every member in every area would have responded, you know, so there may be things out there that we don't know about. So I think that's the first thing, is we need to scope out what actually is there and what isn't there, and as Ruth has said, what can be scaled and spread from what we have. The clinical aid, you know, everyone is going to tell you that is definitely what is needed. And obviously being a nurse, you know, my point as well is that on all of those tables we need nursing there as well, advocating for nursing. We need commissioning that's multi-year. You know, our areas need to be able to succession plan, as the ladies are saying, but we also need to know who we're releasing. I mean, there's no point a district nursing sister being told she's going to release one of her staff in August for September. You know, there's no backfill there. You don't, and we need to know. We need a multi-year. You know, this the very last minute isn't really working for anybody.
Mm-hmm. I think currently we wouldn't have the confidence just in relation to the workforce. I think we know that, and the plan, I think we know that we've known for years the issues that there are, but sometimes it appears that sometimes it's getting worse instead of better. You know, we know that with an ageing workforce, we know that there's a lack of education, but those issues have been highlighted for many years. And we've got lots of regional groups within palliative care who have been able to advocate for all of those things, but to date we haven't actually seen a proper progression of those issues and any resolution of those issues.
Nurse consultant in palliative care for Northern Ireland in the PHA, Sally Convery, did carry out a specialist palliative care workforce census last year with the support of our group, the Regional Specialist Palliative Care Nursing Group. So that's really to try and get a baseline to see, you know, what nurses are in post and what qualifications they have, and that data's being analysed at the minute, you know, so that's sort of the beginning of it. But Orla, I agree with all of the above that you stated. You know, I think it's an issue of the clinical lead, the regional approach, the commissioning, you know, it's all of the above.
Yeah. And that piece of work by the PHA, is it? So they're analysing that data at the moment?
With our group, so that would be Sally Convery would be the nurse consultant in the PHA for palliative care, and the Regional Specialist Palliative Care Nursing Group led on that census last year, so that work's being analysed at the minute.
Very good, because hopefully that's maybe something we could consider
as
part of the inquiry. That would be really important. Thank you.
Okay, Orla, thank you. Danny?
Thank you, Chair. Thank you for that very comprehensive run through as well of all the work that you do, both general and specialist. I'm aware of some of it, but wasn't aware of all of it. Personally, I just probably should state that I'm a nurse and I've delivered palliative care previously within Southern Health Trust, just to declare that interest. So certainly I'm very aware of the benefits of it. One of the things that's jumped out at me, Bernie, just that you had said, the 44.5% turnover in specialist palliative care nursing roles. What's the reason for that, and how
it's quite a significant figure, isn't it? It's so there was workforce planning report done in 2017, and then it was reviewed again in 2023 post-COVID, and that was where the 45% rate turnover that data came from. It would be a mixture of retirement and, also being honest, there would be an element of burnout and staff leaving to go to other specialties, and I suppose coming through COVID as well, you know, but it's the lack of the succession planning. You know, we would have an ageing workforce, you know, so that workforce plan and succession planning with the specialised education commission places, it's vital. You know, we're struggling to meet demand at the minute. So there's just so many prongs to it, you know, with our ageing population, changing demographics. As you are well aware, the demand is growing exponentially, but our workforce is struggling to meet those demands at the minute. So it's critical that we do something about it now, you know, about the succession planning and the education, the training positions.
When we looked at that in 2016, Danny, we were looking at the projection that those commission places that we had at that time would continue on. It's because at that period I was working in one of the trusts as a specialist palliative care nurse, and that then didn't happen. Those figures dropped off, which then meant what we had projected to balance out against retirements, it didn't then follow through.
It's another example of a great piece of work that was done, and a lot of great work went into it, but it never was acted upon or delivered on because of lack of funding.
So at the minute, because of the lack of commissioned places, you're basically losing people out one side and you're not bringing them in the other. So
it's very challenging.
Just
yes, I suppose we should say that we do have a desire for succession planning. Like we will try very, very hard, and we will, you know, we will support and we will coach our staff as much as we can, but our hands are tied without that commissioning in place because of the expert knowledge and skills that the staff is required to work within specialist palliative care. But I have to say that the desire is there, but our hands are tied at this point in time.
That's where our career pathway would make a big difference. You know, if we had a specialist palliative care career pathway, the newer posts of AMPs, and I'm a trainee at the minute, due to finish in September. There's 4 of us going to be qualified in September, but that role in palliative care and nurse consultant roles is vital to attract staff into because if there was no development, you have to think about attracting staff into the role.
And as you would imagine, the impact of that is huge within the generalist staff when you haven't got sufficient specialist palliative care nurses there. The general staff in the wards and care homes and district nursing, they're trying to access advice and support, and they don't have enough education or support as well, which they need as generalists, and they don't have enough access to that either.
I think it's so important as we develop these new roles that the NPs are supported as well in the role, because the caseloads can, be massive, especially given the reduced workforce in some areas and the lack of specialist trained nurses. So it's really important that we place a lot of value on those staff that we have and ensure that they have the correct support to enable them to carry on their roles as well.
Thank you. Another thing that was raised was just the DNARs. Having to, again, and something that has come up here previously on a previous evidence session, people having to restate and ask the same question again and again. Incredibly distressing for patients and for families. How do you feel we could get around that?
Implementation of advanced care planning and respect, which has been implemented across the rest of the UK. What I would say, Danny, is this isn't new. I took up my post in Belfast in 2011, and we did not have a regional DNA CPR form then. So it isn't new. It's just as we're seeing more patients within the community setting, especially, because that is where most patients' preferred place of care is, or they spend a lot of their time at home. We're just seeing this coming up more and more, and our members would tell you conversations that they have had or experience they have had, where maybe they have had a syringe pump up in a patient and they've come along to find an ambulance there or carers attempting resuscitation because there's no documentation. We would hear many of those in my own practice. I've seen that happen as well. It's really distressing. And when it gives you're in a home providing end of life care, but at the same time someone is performing CPR, it's a real contradiction, and it leaves the families really distressed and confused. And I've had conversations with patients' families who have said, but why did they attempt resuscitation if you told me that my loved one was at end of life? So they carry that distress with them after the event, as do the nurses.
And the ambulance crew. And it's great to hear that paramedics are having now, the power to make clinical decisions when they're out in the home, because, as Karen said, I have personal experience of that too, and it's horrific. It's not only so undignified for the patient and the family, but for all those staff that know it's the wrong thing to do. So it's very welcome to hear that paramedics are having
That was something that the ambulance service did raise, that they are doing that now, and the paramedics are making decisions in that area. They shouldn't have to. It should be very clear, and certainly a decision with such huge consequences as that, for the family and for the patient, it should be very clear. So hopefully that's something we can take forward. That we can improve on that. Just the other thing was Encompass. Now we hear again and again, and within the trust, within most of the trusts, will already have access to Encompass. Not Western, I believe.
No, there's Southern go live in May next month.
And then on the other side, on the specialist side, hospices obviously wouldn't, but
read only.
So the Encompass is within the trusts, so the specialist teams within the acute hospitals will all have access to Encompass and will use that. And you're right, by I think it's the 8th of May, all trusts will be on Encompass. It's just the hospices only have read only. That's a huge issue for us in terms of connectivity and communication. And it kind of can slow down the transition of care between one site and another, and also from the community side then into the hospital, we would have a process where the hospice nurses can make referrals in to the palliative care consultants for advice, and we've had to revert back to doing it on paper because they don't have access to placing those orders through the Encompass system. So I think that's quite an urgent thing that needs to be resolved very quickly.
You've went backwards and are now using paper referrals?
We've had to revert back to using a paper because the hospice community teams can't place an order within the Encompass system, and it's down to that. Obviously not having access, they only have access to read only. Whereas if we were to place an order between a trust and a trust, we can do that electronically, and we have that communication between the trusts, and each trust then can see the patient's record. Now, within hospice, you can see the patient record, but
yes,
that's as much as you can do with it.
Just read only.
And no access within the care homes at all, and no discussion about it. And as Ruth had said, we have about 10,500 of our population in nursing beds within the care home sector, and a lot of those patients would be supported with palliative and end-of-life care, and the nurses there have no read-only access, no access at all.
They don't have any read-only?
No access whatsoever, and no discussion about it either, Danny, that we've heard of.
Okay. That's concerning.
You can imagine even with the hospices that, if someone is with the hospice service for weeks at a time, and the input that they've had and the changes that they've maybe made to their care, but then there'll be no record of that if back in the trust room.
There's no discussion, it hasn't been raised as something that...
Oh, it has been raised, but there was no, prior to this, care homes wouldn't have had access to the electronic care record, so it has been discussed, but there's no suggestion of if it or when it would happen that they would have access.
Okay.
Thank you very much.
Thank you, Danny. Linda?
Thank you, Chair, and thank you very much for the presentation and for the paper that you already gave us. And the Chair is right, it was extremely informative and covered really an awful lot of what we may have wanted to ask. I suppose, I think one of the things that we probably do need to, Chair, is not wait to the end of this inquiry. I know that officials are probably listening, and I would be really hopeful that they're not waiting on a recommendation coming out of this inquiry around the DNAR, because for me, I know we've just referred to it around the paramedics having the ability now to make calls on this. They shouldn't have to. They shouldn't have to. They shouldn't be in that position, and families shouldn't be in the position where they're standing there thinking, is this the right thing? Is it not? And paramedics certainly shouldn't be in that position either. I just can't get, I would actually like some answers now as to why that is not happening, why we are still talking about this even this week after the presentation we had 2 weeks ago. I just think to me, that is just utter madness that we're in that position for families and for people who are end of life to actually be causing trauma. And that is exactly what's happening. Trauma has been caused to families, to people who are dying at the very end of their life, to the people who are looking after them. And I really would like us to push hard on that now. Just in terms of the nursing and the workforce, Orlea actually has covered that well, to be fair, in trying to establish how we can, in terms of this inquiry, look at how we follow that through, how we kind of make sure that it is addressed. But do you have confidence that you're being listened to in the department? Do you have confidence that the departmental officials, and this is my position to put you in, to be honest with you, given your role, but that the departmental officials are genuinely listening to the solutions that you are coming to them with? Because that's all I've heard in your whole presentation, and it's all I've seen in your paper is solutions. Not any, here's what we need, well, you've said what you need, but you've put solutions into what you need. So you're not coming saying, there's all the problems. Can you fix it first? You've come and said, there are the challenges. here are the solutions, how can we work together? Can I get a sense of, do you believe the departmental officials and even trust, you know, chief executives are listening to you and that they see palliative care as a priority for them?
And I think that honestly, we are a lot of voices, and there are voices for mental health services, there are voices for midwifery services, there are lots of voices saying what is needed, and you kind of get caught in that, where there's a lot of people sort of trying to put their point across. From a nursing perspective, I do think that we're listened to. It's what can be actioned. It's the resources are not finite. I think that is really the bottom line. It's not that people blank us or don't listen to. They do listen to us. They just don't really have the resources to take forward what it is. Even if we come to them with the solution, I think that there would be an agreement that yes, that would be a solution. It's how they action that.
I think all of us.
Sorry,
Linda. No, I just was going to say, I think all of us that work in this field are just so relieved and delighted that this inquiry is taking place, because, as Karen said, these issues aren't new. Well, a lot of them, 90% of them are not new. And we feel we've been asking and we've been hearing it time and time and time again. And this inquiry is just so welcome. So we'll have to have hope, that and be positive that something positive will come out of this and palliative care will be prioritised. Because we'll have to remember what we're doing this all for is to improve the experience for these patients and for the families, and that's why every one of us are in the role we're in. And, so it's hard to answer whether we believe we're being listened to. All I can say is that we really hope as a result of this that we will be, and it will be prioritised.
We have, as Ruth has said, we have a palliative care network of RCN members in Northern Ireland, and when I wrote to them and asked them if they could look at the questions that you had for the inquiry, I was blown away by the responses. And these are nurses that are out there, frontline nurses, putting in the hours, and they were coming back in the evening, they were writing back to me, they were doing Zoom calls, so there's a real will and there's a real want there with our members, for their voices to be heard within the inquiry, and we're really pleased with that.
I have no doubt there's a will, because it's this, you don't do palliative care nursing unless that is at your very core. This is not, and it's no disrespect to every other nurse that's out there and do, but palliative care nursing is a specialism like no other, probably. So I can understand why they would be very passionate about it. I'm sorry, did I interrupt? Somebody there was about to speak.
No, sorry. I just said, they just always wanting to make it better. I think is the, I sense a wee bit of frustration maybe from you, Linda, because you hear those issues coming to you as well. And I think that's probably, as Bernie says, we are hopeful and we do hope that we are being listened to, but there is probably a sense and frustration in that, the time and sometimes in progressing these things. But again, hopefully this inquiry will help us to continue to highlight these issues and get some.
I suppose honestly, from us too, we are hopeful too. That's why we're doing the inquiry. Like we're not doing it for the sake of passing time, certainly not to waste your time. So it is important to us, and we are hopeful. I think maybe, obviously there are funding issues right across the board, but for me, some of what you've talked about is actually, there is money can be saved in other parts of our, in other parts of our services by doing the right thing in palliative care. So I really want the department to start looking at doing things differently, but I know that they need funding in order to have them to be able to make those moves, but there are definitely some things that can be changed. And for me, it goes back to what Deanne said earlier and what we've raised repeatedly, keeping people out of hospital, keeping people out of EDs, allowing them to die with dignity. And it's not about keeping them at home because you don't want them. It's about, because that's what's the right thing and the best thing for them. But it does, the end result of that is that they're not sitting in EDs, that they're not ending up in hospital beds where they shouldn't be, and there are savings in terms of resources, but it has a benefit for everybody. So it's about doing the right things, and that's not always extra. Sometimes that is actually doing the right thing to make sure you don't have extra work. So no, really appreciate the presentation. Thank you, and thank you, Chair.
Thanks, Linda. Thank you, Deanne.
Thank you, Chair, and again, thank you for the presentation and the work that you do. It is really, really important. A couple of things just maybe I haven't taken them down correctly, which is probably right actually. So you're saying that there's only a 24-hour district nurse service in 2 trusts in Northern Ireland. Which 2 trusts are those?
Belfast, South Eastern.
And that is a general district nurse service, not a palliative service?
Well, they will provide palliative care response alongside, there's maybe Marie Curie services in some of those areas as well. But, you know, palliative and end-of-life care is quite a core component of district nursing, and they're the key worker because of that. But yes, just those 2 trusts have 24-hour services.
So once again, a lot of what you've highlighted is simply this kind of postcode lottery for services across Northern Ireland. I have said this before, but it is worth saying it again. I do find it quite incredible that we had to launch a palliative care inquiry for the department to scope out what services it actually was commissioning and what else was out there. I think that is neglectful. And I just checked one other stat, so because I write all these things down in my little health book and go back to it every now and then. The demand for palliative care is projected to rise by 32% in what year?
From 2023 to 2048, and that came from a Marie Curie report.
2023 to 2040.
Yeah.
Very, very significant. So if we're not going to plan now, we're going to hit absolute crisis point in the not too distant future. And that's also a point for us all to be worth reminding. So, I mean, I appreciate a lot of what you've said. I just want to cover maybe one aspect of it, and that is really delivering palliative care in an inappropriate setting. So in January, like many people here in the Health Committee, I was in ED in Craigavon. We were visiting as opposed to being there, and it was brutal to say the least. It was for staff, for patients, for ambulance service. It was very, very difficult. In fact, I was actually visiting in Craigavon last week, and as I was going in the main door of the hospital, an ambulance driver came rushing over to me to say, "Diane, I've been here from 10 o'clock this morning with a really ill patient, and we still haven't got a bed." And that's the pressure that staff and nurses are under, and doctors and so on. But that is, you know, to be the primary caregiver, that's the pressure that nurses are under. So how does this, I hate saying it, but this concept of corridor care impact on palliative care?
Dan, if you wouldn't mind, the RCN report on corridor care that we released in January had thousands of stories and a chapter in Northern Ireland. And the very, very first story on the first chapter of Northern Ireland is, "I work as a clinical specialist in palliative care and on occasion see patients who have complex needs and advanced disease in a corridor bed. The nature of our work demands sensitive conversations, which can be very difficult to negotiate with the family and the patient in a corridor bed." And that really, you know, there is stories there about privacy, dignity and compassion. And these are the words of one of our nurses here in Northern Ireland. And it takes a lot for a nurse to complete something like this and put a story online. So there's a lot of strength of feeling behind that. And that's just what the nurse, you know, is saying there, you know, with how that person feels and those that are important to that person when they're experiencing their end of life in a corridor, escalation, boarding bed, whatever it is that they're called. You know, the moral injury to the nursing staff with this, I think we will see this as years go on, that you're trying to provide this care and the care that's not done as well. So to answer your question, it's extremely difficult.
And that's also one of the reasons I continuously ask the question about nursing availability to keep people out of ED situations who are in that very, very vulnerable position. And I do think that is massively important. When we think of palliative care, we don't always think of things that are outside the scope, maybe of cancer, heart disease, etc., etc. And I noticed in some of the briefing papers the issue of palliative care connected to mental health illness. Do you want to comment on that just very, very briefly? Because I do think that we need to consider palliative care in all of its senses, and not just in one.
When we talk about our network in Northern Ireland, we have nurses that work in mental health and learning disability and GP surgeries who are part of the palliative care network. So it just kind of shows you how wide-reaching nursing is. But yes, we have a section in our report that was provided for me by a mental health nurse. Yeah. And she talked about some of the patients that she went out to see, and spoke to me about a patient that she went out to who had severe mental health issues and addiction issues, who was at end of life. And when she got to their house, they had a blow-up mattress, one knife, one fork, one spoon, and had taken them, because of their mental health issues, had taken them a long time to present to their GP and hospital. So we do talk about that parity of esteem, you know, the people with learning disabilities, with mental health issues, homeless, you know, people within our justice systems, you know, often they don't have equal access to services, and a lot of the time is recognising them, that their mental health is different than their palliative care needs. You know, it's sort of, and them seeking help and knowing where to go as well with the other issues that they're dealing with in their lives.
I think it is actually important that we spread the net, to speak, as far as we can in relation to that. And just one last thing, just for clarity again. So when you talk about specialist palliative care training, is that for nurses who are already qualified, or is that like sort of the way you can choose to do your training in children's nursing or
post-registration? We have specialist practice qualifications that registers you with the NMC. So there's district nursing, there's health visiting, and then there's adult. And that adult can be palliative care, emergency care, respiratory. There's a list of them, and then you hold sort of dual registrations, that you're a palliative care nurse, or you're a district nurse, and you're a registered nurse as well.
Thank you very much. I think that's a really, really important presentation from, as you say, the people who statistically will deliver, in terms of numbers, most of the palliative care for Northern Ireland. Thank you.
Thank you, Diane. Karen, Ruth, Bernie, Denise, thank you very much. That was much appreciated. So, as I said previously, I mean, hopefully our report will do your work and your contributions to your inquiry justice.
We're always happy to provide any further information if there's any questions beyond today.
Thank you.
Thank you very much.
Thank you.
Thank you.
Okay, members, just going to move on swiftly there to item number 7. So, departmental briefing, governance arrangements for the new build of the Children's Hospital. So, can I refer members to papers at tab 7, includes departmental correspondence relating to the contract award timeline. Paper was circulated by email on Monday, as the department had marked it as confidential, and a departmental paper at page 2 of the table paper. So, I am just. Can I welcome Philip McClay, Director of Health Estates, Department of Health, and David Porter, Director of Services. So, gentlemen, thank you very much for coming. And as always, I'm just going to hand over yourselves. We just want to make some brief introductory remarks before we then ask questions.
Yes, thank you. So the Minister has asked me to represent the Department today in my role as Director of Health Estates, and I am joined by David Porter, Director of Strategic Development at the Belfast Health and Social Care Trust. David, as you're aware, is the Senior Responsible Owner for the new Children's Hospital. So in advance, you've received a briefing paper on the new governance arrangements in place for the build of the new Children's Hospital, the lessons that have been learned from the maternity hospital build, and confirmation that the financial errors in the SIB ISNI tracker report have been rectified. Given the limited time available, I do not propose to reiterate the information provided in the briefing, and just suffice to say that David and I are content to take any questions that you or the committee may have.
Okay, thank you. Thanks very much. Just in relation to the timeline that was provided to us, so, I mean, at the meeting last week, became aware through media coverage during the meeting that there was a difference. One of the contractors had pulled out, and when this was raised with the minister was surprised that we were surprised. So, not to elongate the thing, I'm surprised now that the minister was surprised that we're surprised, because I mean, no, but that's how kind of farcical it's got. I looked through the press releases, etc., and the media at the time, and it all referred to BAM Graham in terms of the contract, and at no point up until last week was I, and I'm not saying just me, but nobody that I could ascertain in the public domain was aware that that wasn't no longer. So, I mean, we can argue whether it's a big issue or not, but unless you can clear up for me how we wouldn't have been surprised last week, and when I got the time frame, it became clear that there was no public announcement until the media made it public last week. So am I still correct in that assertion?
Yeah, so Chair, just want to check you've got the timeline. So I responded with a timeline on Monday. I know there's correspondence from the committee. There's 3 or 4 questions from last week, so we haven't formally responded. So you've got the timeline. I wasn't aware, but that's great. So, yeah, I can't comment on. The minister was advised that BAM had pulled out of the joint venture on 21st of March was when I formally notified him when the contract had been executed and that BAM had pulled out. I'm sure verbally I had reported that to my superior, so it probably was verbally. He was aware at that stage. On 21st of March, I confirmed it in writing. So that's the first thing. In answer to your question, is it a concern? Graham Construction wrote, you'll see from the timeline, etc., and we're not concerned. As I said last week, we can't force any contracting entity to do anything against their will. And as you'll see from the timeline, things moved on at pace. But we only became aware after we had formally issued the Graham BAM Healthcare Partnership formal execution document on the date was the 11th of March.
And when you say there things moved on at pace, so I mean, obviously nobody wants to see any delays, but I mean, I'm not an expert in these things, which is why we're asking these questions. So, I mean, if I was involved in sorting out the contract for something as costly as the construction of this hospital, I am probably assuming that the first contract negotiations and the due diligence and that was a lengthy period of time, and then whenever BAM has pulled out, moving from that to being satisfied that Graham was able to go on wasn't a particularly lengthy period of time.
So all the discussions throughout the formalising the contract were with Graham BAM Healthcare Partnership as an entity. The main people that we were talking to were representatives of Graham, but in the background the commercials were being dealt with by BAM personnel. So I think there's 2 BAM staff who were working in the background on it. I think it's fair to say that our experience of the Graham BAM Healthcare Partnership has been that Graham have been doing the vast share of it. And I did ask the question at the time, when I asked, is there a problem here that BAM have pulled out? Was given assurance or wasn't? I did ask, well, it begs the question,
what were they needed for?
Why did you form a JV in the first place? So that question was asked, and it was about sharing risk. So diversifying the risk. So as we've talked about before, unfortunately we're getting more regular up here all the time. So we've talked, these are risky projects. There was one contractor who submitted a price to build the children's hospital. So that tells you, you know, there's a lot of contractors in Northern Ireland. You know, the next question is, well, why did only one submit a tender? You know, that's a question we're asking ourselves too. But fundamentally, it's because these projects are inherently risky and complex. And as I said last week, we are under time pressures. We're all familiar with that we need to get this project commenced. And when BAM pulled out the letter, and I haven't shared all the correspondence, but I assume you may want to see that. But, you know, the letter was, John Graham Construction are willing to do the job. BAM had written in their letter that they are content for John Graham Construction. And at that stage then, we issued the PQQ1, I'm getting into the detail here, but the pre-qualification questionnaire, which was what financial notation you had to have and what technical ability you had to have. Graham's, obviously, we issued that to them and we told them, can you turn this around quickly to get that information? And Belfast Trust and Health Estates officials reviewed that, and the decision was that John Graham Construction Limited had the bona fides to do the project.
Okay. And I mean that essentially, I mean my question was the same as your question. If it was a combined venture and one pulled out, what was the need for the combination in the first place? And I mean I asked a question about the kind of moving on swiftly whenever that became the case. And I asked the question just so that I can be satisfied from your answer that, you know, yourselves, the department, are satisfied that Graham can endeavour to do this contract.
Yes.
And that due diligence was done to ensure that that is the case.
The Department of Health are satisfied, along with the Belfast Health and Social Care Trust. Yes.
Okay, so I'm going to move on swiftly then, because I mean, essentially, what you're here for today is about lessons learned from previous. So I'm going through some of what you've wrote and some of the kind of press cuttings at the time. So at the time, there was a bit of media around the new hospital and the contract, etc. And the minister had said that he had asked for key lessons to be applied ahead of the contract signing for the new children's hospital, and then the department subsequently said that the minister asked for these key lessons and these lessons were applied. So with regard to these lessons, your response is around governance and strengthened oversight, which is good. We would expect that. I mean, the setting up of project safety groups. I mean, it's saying here also other improvements include submissions of regular update reports to Departmental Board and Health Committee. So the Health Committee will be glad to know that we'll be getting regular updates. Hopefully they're substantive updates. So I want to kind of ask in terms of how this oversight will improve and governance will improve the construction period of the contract. And a bit of detail on what the project safety group will do.
Okay. So David, do you want to talk about the project safety group? Or?
Happy to take that, yeah. The fundamental structure from those project safety groups is it's really as per the guidance that was issued in August last year, updated guidance on water safety in particular, but we have taken those principles and applied them across various disciplines in the new children's hospital and the design of it. The fundamental purpose of those is to oversee the safety of each of those systems, to ensure the standard in each of those systems, but they have a couple of functions and on top of that will assist in the contractual management and the decision making across this as well. So in any given construction project, and this is not looking particularly at any of the previous projects, But in any given construction project, especially in the public sector, there can be times when there's disputes between design team and a contractor as to what the best way forward is. That has happened in the past in some of our projects, and it can become a difficult decision then for the trust in terms of should a change be implemented, should it not. Part of the purpose of those safety groups is to have a suitable forum for that discussion to take place, competence within that to take place, and we're having those groups chaired by subject matter experts, independent, of course, employed by the trust, but independent in that sense that they don't have a commercial interest in the design or the construction, and they can give impartial advice to the trust. So it will help in that decision making, which can be a problem in any construction project, in that we have effectively, it's an arbitration type role in the event of dispute there as well. So it will improve decision making and speed things up in that sense. Will assist in that overall quality control as well. Another aspect of establishing those and bringing those subject matter experts in is to ensure that we do receive any of the specialist information. So again, I'm thinking water in particular in this. It's obviously been quite a focus. So when it comes to developing up something like the project safety plan, the water safety plan, in the past where there was Pseudomonas uncovered, there's issues with the time scale of receiving information, developing those things and so on. And we are satisfied that the best way forward is to have that independent person, again without commercial interest or conflict of interest, to develop those independently and make sure those are in place at the time they need to be in place on the project as well. So again, we see that as strengthening by virtue of the experience, the expertise they're bringing, but also helping in that decision-making process moving forward as well. And then the groups, their primary function is to the project, the delivery of the project, but they also then do provide that assurance function, so they report to the Trust's wider safety groups. So again, for the example of water, to the water safety and usage group. But similar principles will apply to ventilation, fire and so on as well.
I mean, and you've touched on water, and obviously that is key, just given the problem. So, I mean, when I was first reading this, I'm reading what the Minister said about key lessons will be applied ahead of the contract signing. In my head, I'm thinking, right, well, that means, you know, we know what happened with the water in the maternity hospital, so that those lessons will be applied differently now. But when I read down, that's not the case. So, I mean, there's still, I mean, the lessons are more around governance and oversight than that technical aspect of it. Am I right or wrong on that? And that I may be very
no.
And
look, we do appreciate the report. You only got it yesterday, so look, we appreciate there's probably an amalgam. Oh, sorry, I thought it was issued yesterday. Apologies. There's an amalgam of things. So there have been lessons learnt that you know we have discussed with John Graham Construction Limited. I nearly said Graham Bam Healthcare, but it was Graham Bam up until, as we've discussed. But we were discussing things. So the lessons learned, we did know for the water, and I think we've covered it in the paper. We're talking about the water system in the maternity is one big system. I think we've spoken about it previously here. We're now looking at disaggregating the water system into multiple small systems. So we're looking at that at the moment with the contractor. So we did have those discussions and that work has started, but that has to be sorted out as a post-contract change, because there was going to be time, design, etc. to be done, and we had to get the contract started. So we do have time to sort that out, and that's had started before we signed the contract, those discussions, but that's ongoing at the minute. David, and maybe you want to...
The fundamental principles of that change are agreed and have been reviewed internally in the Trust and so on with Health Estates, as Philip said. The key part of all of this is that disaggregation of the water system. So when you have one in the Children's Hospital, very large water system, over 12 stories, it does create several challenges, one of which would have been just in the sort of pressure variance across that system, trying to sort of commission that, trying to ensure that the pressure was managed and so on across that would have been very difficult. But it also then leads to an issue around water safety in the event. Now we would trust that it wouldn't happen, but of course something like Pseudomonas is naturally occurring, it can occur in any system somewhere. It does leave you with that ability to segregate the system, so that you have the assurance that anything that occurs in one aspect, in one area of the building, will not transfer to another, or through the water system, of course. So we're looking at that, just the detail of that, now that the contract has been awarded, as Philip said, but we have agreed the principles of that previously. We do fully understand the need to change that, and it's just simply down to some of the details how that's implemented.
And that, I mean, essentially that's my question, because there's a few issues. I mean, with these projects, you don't want delay, you don't want added costs, and then you don't want any issues that they can't be opened. And I mean, I suppose I'm maybe playing with words, but when it's saying key lessons were applied ahead of contract, and then when we're saying now that there's actually work with regard to water post contract, is that potential for delay or disharmony or disruption?
The key lessons have been applied in terms of the structure of our governance and so on, the structure of the teams. There's been quite a few changes around all of that. As Philip mentioned, we have been looking through some of those other aspects around the design. Some of those had been agreed in advance. We've been looking previously at some of the specification items and so on, some of the commissioning of the systems. So some of those were agreed in advance with the contractor. But now we're looking at the sort of the fundamental design itself. As I said, the principles were agreed. It's just the implementation of that now with the contractor on site.
Okay, thank you, gentlemen. Danny?
Thank you, Chair. This is a long ongoing thing for us, and I know in the Belfast Trust there has been a pattern of these projects that go widely over budget and take a lot longer than they were planned to, and we're at another one that we're about to start. So it strikes me that we're talking about learning lessons from a hospital that isn't open yet, that should be open now, that isn't, the maternity hospital. What's the timeline for opening the maternity hospital at the minute? We
have a multidisciplinary review meeting arranged for Monday. So the exercise that we have been through, that we reported previously to the committee, was one where we have implemented the recommended changes and so on to the system from our water safety expert from that interim report that we advised you of previously. We did say that whenever we had implemented those and had a period of steady flushing and so on through the system, that we would do further sampling. We have undertaken another round of sampling, which was just completed last week. The results are due in. The final results are due in. I think we have just received those maybe yesterday. I need to confirm the exact timescale of that. I think it was just yesterday we received the final results. So we now have all of those results in from the latest round of sampling, and we will be now reviewing that information, the information that we have across the entire history of this building, the design and so on, with the clinical teams, and that's with a review to selecting from those three options that we had outlined previously as well, as to the level of remediation works that will be required.
And based on which one you select, then
that will define the timescale. So we have our first multidisciplinary review with the clinical teams and some of the other stakeholders involved, set up for Monday this incoming Monday. There'll be too much to make a decision on the day. There's a lot of information to go through and so on. So we have a follow-on meeting then 2 weeks thereafter, which is week commencing 28th. I think it's on the Thursday that we're having that second review meeting. And we aim at that meeting to make a decision as to the route forward. So part of this will be the clinical teams and so on have looked at their risks, how they manage things, and it is effectively the amalgamation of those two areas, the engineering side of things, the water safety risks, how the clinical teams operate. So those multidisciplinary risk review meetings are effectively an amalgamation or marrying those two to see what level of assurance the clinical teams have, and what level of remediation we need to do to move services into that.
I appreciate that. So at the minute you can't tell us.
Very shortly. So when
we haven't decided on the way forward yet, so you can't tell us how long it's going to take. So we're learning lessons from a project that we don't know when it's going to be open.
We do know the issues that were involved on it. We know many of the issues that were involved on it, and we're learning lessons from that. So I appreciate what you're saying. I can't sit here and give you that timeline today, but we will shortly be able to give you that timeline. And we are aware of many of the issues that there have been in that maternity. We have got lessons learned from our water safety expert, and we're implementing many of those on the Children's Hospital.
No problem. Just to pick up on something we were talking about earlier, Philip, we only got the papers today. We only got them, I think, before 11 o'clock this morning, which gives us about 3 hours. And I know other members have other responsibilities and things.
Apologies for that.
I know it was only 8 pages.
It's not acceptable. That won't happen again.
Okay, appreciate that. Thank you. I had a couple of timeline issues. Just from the timeline that you sent me, there was a couple of concerning things. Were you allowed to quote from the timeline? Is that?
I think so. I don't think there was anything.
On the 12th of March, it said that you had asked that the contract documentation is executed by no later than the 14th. But it took until the 18th for you to be told that BAM were pulling out.
Yeah, so
it's 4 days in between the 14th and the 18th. Why the disparity there?
Well, I don't know what discussions were going on behind the scenes between John Graham Construction and BAM. So
no later than the 14th was what it said. The documentation should be executed no later than the 14th.
Yeah.
And it took 4 days then for them to come forward and say. So was that a concern?
Well, we were constantly having discussions and geeing it along to get the signature, but so there were discussions in the background, but I've put the correspondence that was in the emails on this timeline.
Okay. It just seems, there's a gap of 4 days there where, nothing seems to have happened, and obviously.
Well, I don't. Well, that I was away at the weekend and have pulled this together.
No problem.
Given the urgency, but it's not right that there was nothing happening. But that was in my emails. Those were the emails that are there. So I've put that. I'm sure there was discussions by various members of my team geeing this up because we wanted the contract signature. To get in the contract here.
Did you suspect at all during those 4 days? Do you think was there a suspicion?
Well, as I've said, we can't. We look at the bigger picture. We can see what's going on in the media down in Ireland. We know the scrutiny up here, so we probably were surmising that there could have been an issue, but we can't intervene in that. We were just saying, guys, get this sorted out. And we need a resolution.
No problem. No later than the 14th, but then the 18th. It takes the 18th. It does seem odd. One thing I wanted to raise as well was just about the critical friend role that's highlighted. And I think you'd referred to it there. The critical friend role is simply from inside the trust. Is that correct?
No, there's 2 critical friends. One of whom was previously employed in another trust in the delivery of their major capital projects at director level. The other had been involved at executive level in the private sector, so it's essentially coming in from public sector and private sector as critical friend, bringing that challenge at board level.
Not trust employees?
They are paid by the trust, they're not directly employed by the trust, they're brought in, I believe it's through the leadership centre. But
it does strike me that there is a pattern here of the projects going over budget and over long again and again, and certainly we've seen the maternity and we've seen the acute care mental health hospital as well having problems with water again, the heating system, and I don't know how that's going to be resolved. I don't know if a plan has been selected, whether or not you're going to.
Don't have an update from what we had last week when we reported it.
Okay. I understand regular reports are going to be part of the governance of this. Do you think you should be looking at an independent inspection of the build at key milestones so that we can ascertain if it's moving at the correct pace, if things are being done at time, and if things are being done on budget? Would that be a way of being able to monitor the development of these projects so they don't get out of control?
We health estates are involved in this project. In the department, we will be monitoring this closely. I think we've put the line in the paper. For the last 10 years, we were relocated to Department of Finance. which did have an impact on the governance. Now we are back in the Department of Health. We are fully in the line of governance assurance, and one of the lessons learned we will be doing is, personally speaking here, I will be keeping a close eye on this, and my team, which we are making sure that there's sufficient resource, etc., on it to ensure that those checks and balances are happening. But in terms of inspection, I think we both would agree, David, that there is merit in having possibly looking at more on-site inspection. The caveat to that is, in Northern Ireland, we do have a dearth of that resource. So it's whilst we both agree there's merit in it. Actually finding that resource can be difficult, but that will be one of the things we look at.
And I think that would be of value, even just sort of ongoing supervision of the works on site, and so an increased level of supervision on the works on an ongoing basis. Not just
an independent evaluation of that.
Well, it would be better if it would be independent. It would be better if it was independent, but as I say, there's a dearth of this resource about, and so we need to look at how best to do that.
One last question. Sorry, just when we were talking about the water systems, the new guidance that's come out from the NHS has suggested that there should be water systems per floor. From what I understand from reading the report, is that correct?
NETB 2024/3 is the title.
August
yeah.
24.
That's correct. Yeah, it recommends
10 floors in the new
10 floors of clinical accommodation, and then there's interstitial floors of plant and so on as well.
So that's going to be quite a difference from the original plan. I take it the plans need to be adjusted.
No, the plant that we're looking at each floor, it's not a huge area, it's not a huge size, so we're looking at potentially plate heat exchangers for the hot water supply and a pressure vessel and so on, but it's not that there'll be sizable water storage at each floor or anything like that. At the minute we're not looking at that. Right. So it's not that this is going to be huge volumes of plant at each floor, but it's sufficient to segregate and dose for each floor. But we're looking just at the minute at where that will be situated, of course, to not interfere with clinical operations and so on. But no, it's not that there's a huge volume on each floor.
Okay, thank you for that.
And just before I bring Diane, see the kind of stuff that we're talking about here, where Stanley talking about an independent inspection, or the questions I was asking about the additions to the contractor, the last point about maybe additional water pumps in each floor. Is that extra costs within what we already know in terms of the cost, or is this all of this discussion that we're having within the current costs of the hospital?
So the costs that we have at the minute have optimism bias within them, which will allow for some change. Some of these changes we're talking about could be savings. Can be pluses and minuses. So it is our hope, and I think we've said it before, it is our, short of something extraordinary happening, we are confident that we can deliver within the financial envelope as it sits at the moment. Now, topical issue, Trump's tariffs or whatever, we can't cover all that, so I am caveating that, but it is our hope we can deliver this project within the financial envelope as published at the moment.
And not to crack a joke on such a serious issue, but optimism bias, I think is
it's a term, yes, but that's the recognised term for it. Yeah,
fair enough.
Yeah.
Diane.
Thank you, Chair, and thank you for coming to the committee. Can I ask, first of all, why is the person who was the senior responsible officer, the now interim chief executive, not here to actually answer questions on the lessons learned, given that she was responsible for the maternity hospital? She wasn't here last week either. So it led to a lot of I wasn't there, I didn't know, it wasn't me.
There's considerable pressures on our timescale, as I'm sure you can understand. In our
Surely
diary,
there can be nothing more important than answering questions to a statutory committee of this Assembly.
I was just going to say, our thoughts on this were this is very much forward-looking to the Children's Hospital. That's my responsibility as the SRO for that.
Well, your
unit.
paper
So
indicates that there's some questions for us to ask. So
means, yeah.
I'll give a starter for 10. So when we talk about the background in the paper actually says the Belfast Trust has in recent years received a satisfactory annual assurance from internal audit and has provided formal assurances on internal control and governance. However, next sentence, there have been several issues in relation to estates and capital development functions within the Trust which gave the department concern. What were those?
What's the issues with the water, for example, these projects?
So that's all. It's just the issue with the maternity hospital. And if we hadn't asked all these questions, we would never have known any of these issues. Is that right? I mean, that indicates to me that there are issues, several issues. This is the word. This isn't my words. Like, this is what's written in front of us, in relation to estates and capital development functions within the Trust, which gave the department concern. I think it would be well worthwhile if you wrote to the committee and indicated exactly on paper what those issues were. Is that okay? I think that I do think that it's important to have transparency and clarity in relation to this. It's really important. I must say I am underwhelmed by all of this. I think that I have called for an independent voice looking at what has happened in the Belfast Trust with the critical care building. We have the acute mental health building, which seems to be an absolute shambles. We have a maternity hospital costing almost 100 million. And a year after it was announced that it was finished, we still can't use it, or almost a year. And I'm looking forward to a children's hospital that is built without problems and on budget. But I do think that we need to have a critical look at what has happened in the Belfast Trust. And you can't write a sentence like that into a paper to this committee without actually telling us what those problems were in detail. Can I ask a couple of other questions that just keep bugging me? So this paper indicates that in the governance issues, so we're going to have a new SRO, and David, that's you, the SRO for the Children's Hospital, that's fine. But you're also creating project safety groups. And you're going to create a project safety group for water, ventilation, medical gases, electrical and fire safety systems. How are those water safety groups different to the water safety and usage group, which was in the Trust monitoring the maternity building, and which, when I asked the Minister a question, he indicates in his response that the water safety and usage group notified the Trust's original organisational governance and steering group of issues concerning the new maternity hospital project on the following dates: January 23, March 23, May 23, September 23, January 24, April 24 and October 24. So right up almost to the handover of the maternity hospital, the original water safety and usage group, which is set up to advise on water and safety issues, according to the Minister's answer to me, advised the Trust of their concerns on all of those dates. Is this new group going to be listened to? Does it have any extra powers? Can it make people respond to them? Because clearly the original water safety and usage group couldn't do any of those things.
The difference, if I may, and I hope it's not too much of a simplification, is the water safety and usage group is part of the assurance structure of the Trust. So it's not so much a doing group, Diane, the project safety group sits underneath it in that governance structure. Its primary role is the delivery of the project, the safety of each of those systems, fire and ventilation and so on. But they are very much doing groups, so they will be responsible.
So this is going to be a delivery group. And who's going to monitor the delivery group's role? See, it seems to me that we have an awful lot of groups here and people all over the place. Who's going to monitor that? And have we any assurance that that won't happen again? January 23, March 23, May 23, September 23, January 24, April 24 and October 24. This group warned you about the systems, but nobody took any notice. That's exactly why I think that the senior officer who was responsible then should be here now.
It's my responsibility to make sure that any of the concerns raised in those groups will be heard and will be dealt with, Dan. So that's certainly something that I take very seriously moving forward, and I can assure you that it's something, the structures that we're setting up are set up to ensure that each of those groups will have adequate competency within them. Those, I have told each of the representatives, be it the design team, representatives from trust, capital planning and redevelopment, or estates and so on, each one of them will have a voice, but it will be a collective discussion. They may not have a decision in the group, but they will have a voice, and it will be my responsibility to ensure that those voices, those concerns are heard and they are properly dealt with within the project moving forward, Dan.
And David, I accept you. I've known you and I accept your bona fides. I do genuinely do that. But I do think that we will need to be assured that the same situation that happened with the Water Safety and Usage Group that monitored the maternity hospital, that does not happen with the Children's Hospital. Because I think it is quite disgraceful that on all of those occasions that people were warned of the difficulties with the issue. And I mean, I'm reading exactly the response that the Minister gave me in a written answer. So I'm reading exactly what he said. And I think that those kind of things need to be followed through.
I appreciate there's a further question that we're pulling together some of the information on at the minute, just to show how that was escalated within the assurance structure at times as well. So I appreciate that's taken a bit of time. There's quite a few records to go through in that, and so apologies for the time scale on that, but we will be responding to you with a bit more information on that escalation.
Thank you. So just to avoid any sort of, or for my simple following of the issues, the Minister on the 27th of January told the Assembly that any key lessons would be applied before the signing of the contract for the new Children's Hospital. On the 14th of February, he told me in a written question that it would not occur prior to the signing of the contract, but he was determined that there would be the lessons learned would be implemented. And on the 19th of February, he said that he had asked departmental officials to ensure that they were applied ahead of signing the contract for the new Children's Hospital. You can appreciate how much confusion there is here around, and back to Danny's question about we're actually taking lessons on a project that still has problems and actually isn't, completely sorted out. If people are concerned, I think that we can see why they're concerned. And sorry, just to go on to another question. Many of these projects were set up with the department to achieve net zero in relation to them. Can net zero be achieved in any of these projects, given the fall of the energy project, which has spent 10 million in design, but has now been red flagged by the department as something that can't be delivered?
Achieving net zero, the building was designed to the extant building regulations at the time. We have looked at providing options within, for example, the heating supply, so that in the future, if more energy efficient heating sources were particular thinking of a combined heat and power plant, if that is provided in the future, that we have got mechanisms within the existing design on the Children's Hospital that could be retrospectively fitted in at a later date once that new installation is in place. And so as things stand, it was designed to the extant building regulations at the time, but we're looking at providing that flexibility for additional plate heat exchangers, so that if another supply can be brought in that's more energy efficient, that can be fitted at a later date as well. So
you think that the energy project is deliverable at any time?
Well,
given that already 10 million has been spent in designing it?
The Trust took the decision to put that on hold. There is a need for resilience in the site moving forward in the long term, and we absolutely appreciate that, and we appreciate the need to do that in light of the net zero targets and so on, Diane. So I don't have the answer as to exactly what that will be moving forward. That project is on hold at the minute, but it is something that we will be looking at in the future.
And just help me to understand, and I'm no expert in this, so I don't know any of the answers in relation to this. I mean, like the chair, I was surprised that the minister was surprised that we were surprised, because we weren't told about any of this in relation to this. But sorry, my colleague prints everything upside down. So on the 18th of March, you got an acknowledgement that the construction would go ahead with only Graham as the builder. That's fine.
On the 18th of March, we wrote to Graham acknowledging receipt of their letter of that morning, stating that it contained a letter from BAM saying they were pulling out.
Fine.
Yeah.
Okay, that's fine. And you did the due diligence between the 19th of March and the 21st of March?
That's correct. So the PQQ1, there was a number of the contractor had to show that they had successfully constructed healthcare projects. That was assessed, and they also had to show that they had the construction line notation for building hospitals, which was also checked on that date.
I have no sense of this, so I don't know.
Fine.
Is it a rigorous process? Is it? It certainly isn't a time-consuming one. Is it a rigorous process?
We got the answers and checked it. It's a desktop exercise to check: has the hospital been built?
Okay.
Yes. Is it? And does it meet the requirements? Yes.
Okay. Thank you, Chair.
Thank you, Dan. Colin?
Thank you, Chair. Sorry, I've had a bad signal, so I've struggled to hear all of what's been presented, but I suppose it would be fair to start off by saying that given the way that the Department and Belfast Trust have run things, I'm not at all surprised that everybody's surprised that nobody's surprised, because it just seems to have been run like a farce from the thick of it, where things just go over budget and take longer than they need to. People aren't aware of the faults and the problems that they are, and when we get these faults and problems, it leads to significant time lag in being able to open the premises. And it does feel a little bit like lots of the safety nets that are now being put in place are being retrospectively put in place because of the concerns that we've raised here in this committee. And we're not experts, and that is a bit concerning, because we would hope and expect that projects of this magnitude that are using the public purse and spend as it is would have all of these various protections already in place. I refer earlier to the remarks made about whether or not there would be a close eye kept on the progress of projects. I know from my time in council, when we built new premises, we were presented with very complicated but very detailed graphs that had the little step by step and where the various achievements would be in the project and what would be done and who would be signing it off.
And most of those projects didn't go over budget or take a length of time. So it's a bit concerning that it feels like that still isn't really embedded within the practice of the department and the trust. And it is very difficult to look to the future at the way these new belt and braces procedures are going to be put in place if we can't question what has gone on before. But that certainly isn't your area of expertise, because you weren't necessarily involved in these projects previously. And I suppose in terms of questions then from that, one that I have is about the water issue, because again, I echo what Diane and others have said. There appears to be a palpable frustration amongst those that were involved previously, who are basically saying, if we cut to it, we highlighted that there was problems, but nobody listened to us. And then the problems mounted up and became so big that the project can't continue, or went over budget, or couldn't be opened. And they are being replaced with more groups of people. So we do want to get an assurance that those that are involved in those projects and in those groups will truly have their voice heard, and if there are concerns, that they will be followed up. And in terms of the water, if I could ask about the Pseudomonas and other issues, we've mentioned a lot about the things that we're going to put in place to try and monitor it, but have we actually worked out where the problem happened the last time? And is there anything that can be done to mitigate against that? Or is it the sort of issue that you just can't mitigate against?
I don't think we can sit here, Colin, and say that we have identified a singular source, in all honesty. But what we do know are that there are lessons learned as to what may have been contributing factors, and we are looking at that with the contractor. There are a number of issues there, so again, I can't go into the detail of all of them. We are looking at things like when the system is filled with water. So essentially, the best way to avoid water risks is not to have water in the system and keep it dry for as late as possible. So it's when that's filled, we're looking at pressure testing with air and so on, instead of for leak detection before the system is filled, to allow it to be filled at the very last minute. And then of course there's the suitable water safety plans and flushing protocols and so on when that is in place. So there are a number of areas there that we, again, I can't pretend that we have identified singular source on the Pseudomonas and the maternity build, but we are aware through the maternity hospital, but also through some of the new guidance. And as I say, that was only issued in August last year, and the structure of some of these water safety groups are very much based on that guidance. But we are taking some of the guidance from there around systems to be put in place to mitigate any risk of this reoccurring. So it's the point of entry filtration, again segregating those different areas of the hospital as well, with point of entry filtration for each ward or each area. All of those are measures in place that will mitigate the risk of this moving forward.
And maybe just on that then, is it a case of you can't find out what the cause is now because you can't retrospectively look back, and that you are in the future putting in measures that will pick that up should it happen? Or is it that in a case like this, it's normal practice if something like this happens that you just don't know what the cause is?
I'd struggle to define what is normal practice on it. It's certainly my first experience of it, Colin. So all I can say is we certainly haven't been able to identify a single point of cause on that, on the maternity. Whether we're certainly working with every aspect of the design and the systems in place for commissioning and so on to make sure that we mitigate that risk moving forward. But again, as we've pointed out before, this is something like Pseudomonas is a naturally occurring bacteria, and it's not simply the water system that is a risk for bacteria. You know, every human being is a risk for bacteria as well. So there are various systems that we have in place to manage those things and manage those risks on the wards at each level as well. So it's not a singular issue to the water safety. While we appreciate that's very much a focus of the committee at the minute, there are systems that we have in place to manage that throughout the wards when the hospital's operational as well.
Okay, well, look, I certainly feel assured with yourselves leading up the project, and we will get regular updates in terms of the development of the project, which will basically say, are we on time and are we on money? Those will be the key issues I think that the committee will want to know in terms of satisfying the public's concern about another project within the trust, but hopefully that this one will progress without any difficulties. But Chair, that's all I have. Thank you.
Okay, thanks, Colin. Alan?
Thanks very much. Donnie sort of highlighted the issue of the lack of activity from the 14th to the 18th of March. And a possible explanation is that the 15th and the 16th were a weekend and the 17th was a bank holiday. So that made...
Well, with the best will in the world, Alan, I don't think that comes into reckoning, contrary to what the public seem to think. Civil servants are working hard. Just I want to make that point.
I'm sure I would have every conference the civil servants.
But thank you.
We're working 24/7 over those that weekend.
David and myself.
But the contractor may not have been addressing it over the weekend, given the significance of St. Patrick's Day on the Monday. But the from the 18th, I mean, you indicated that was in the morning of the 18th that you got the correspondence from John Graham, and I think the actions that you took between the 18th and the 20th when the contract was actually executed, I think there was a lot of common sense brought to the exercise, and I think that there was admirable urgency also deployed in getting that pushed through by the 20th, so well done on that. But if say on the 18th you had taken a decision to press the nuclear button, as it were, and say, right, that's it, back to square one, we now have to start a new procurement, a new tender operation, what would that have done to the timeline? What would that have added to the timeline to go back to square one and start a whole? And you did indicate that there weren't all that many contractors in Northern Ireland that were queuing up to put in a tender. No. But
so that, Alan, would have taken, by the time we would have got a procurement strategy, because we couldn't do the same procurement strategy again, because as we've already pointed out here, we've got one, so that's not sustainable going forward. So at the minute, Health Estates, in conjunction with the Construction Employers Federation, etc., are looking at alternative procurement methodologies. That takes time, probably allow 3 months for that. Then when you start the procurement, and obviously there's new procurement regulations in at the moment that came in on the 24th of February. So there would have been an added complexity there in that the public sector are getting up to speed with those regulations, so a bit more risk, but a procurement that goes swimmingly, smoothly, with no issues at all, which is quite rare at the moment. Probably you would need to allow 9 to 12 months for a procurement of this size, and then that's probably being generous, because the price to price a project of this size, if you do get a contractor willing to price it, you don't price a project like this overnight. There is a lot of work involved in that. Now, that's not to say that the procurement methodology moving forward won't change, and I think it will change, because it has to change. But I'm going to be conservative. 12 months with a fair wind, probably closer to 2 years. So
I think that explanation certainly justifies the common sense approach that is adopted from the 18th to the 20th. So well done. Thank you.
Okay. Gentlemen, thank you very much. That has been informative. So appreciate you coming before us and taking our questions. Thank you.
Thank you.
Okay, members, moving on then to correspondence. Can I refer everyone to the correspondence list? Is at page 208 in our packs. So just there's correspondence from the Department's Director of Family and Children's Policy at page 210, which seeks the Committee's views on proposed amendments to the Safeguarding Vulnerable Groups Order of 2007. So the amendment seeks to strengthen safeguarding protections for persons working with children by mandating full vetting processes. The proposed amendments can be introduced through an act of the Assembly, but this is obviously going to take considerable time and will cause a safeguarding gap with other jurisdictions which have already closed the gap. So the alternative is to use the legislative consent motion through the crime and policing bill. So British Home Office, who is responsible for this bill, have given a short window of opportunity for the department to bring the LCM, and as such the department will not have an opportunity to conduct a formal consultation on the proposals. So the department is therefore seeking the views of this committee and other key stakeholders before taking a decision on how to progress. So can I ask members if they have any comments, or are we content to support the department in having the safeguarding gap closed as a matter of urgency and bring forward the LCM? So that's our two options. Linda?
Just a question, Chair. So who are these other stakeholders? I'm just concerned, like, I don't know enough about it, just being truthful with you one way or another, but I'm happy to take the direction of the Chair and others on this. But I would like to know who the other stakeholders are that they're talking to in terms of finding out from people who actually do know this stuff inside out and understand what they're talking about and what their view of doing this would be.
I'm going to hand over
That's
to
a Church's comment. I'm happy to take direction on it. I genuinely don't know enough.
I'm going to hand over to the clerk for this. Put him on the spot.
Thank you very much, Chair. According to the letter we've received, the issue in relation to this is that normally there would be a bit of a consultation before an LCM is brought forward. They haven't been able to do that because of timing, and therefore they won't be able to do a consultation with what we class as a usual normal consultation. And what they've said is, and the director said it's intention to also issue a letter to key stakeholders to seek their views. We've got no indication about who they have written to and what the response has been, but the committee has been asked by the department for their views on this.
Suppose, as I say, I'm just worried because we don't know enough about it. That I'm being straight. I mean, on the face of it, it looks like something good. That you would want to. I think Collins has his hand up, and given his background, maybe he knows. No, I thought you were waving. I just thought maybe your background, maybe you know something more than I know here. So go for it.
Colin, go ahead.
I've had to shrink the Zoom screen and the papers at the same time, so I can't find the hand up signal. So, but yeah, look, I think what I can see from this is it would be a good thing, but I do think it would be good to get some more information if it is possible on it, because what it's essentially saying from what I read is that if somebody works with children and young people but is supervised by another adult or a manager in their job, then that person doesn't necessarily need the same level of police clearance. But often any abuse or other things is unlikely to take place in the workplace. It's going to be about how that relationship is built up in the workplace. Yeah. And then maybe there might be something that happens that's more community based. So, you know, I think there are questions that might be worth interrogating if it was possible to do it.
I think the unfortunate thing, there isn't a time frame for that. I mean, we don't have to take a position today. I mean, I'm happy to take advice from the clerk. But the department haven't, I mean, they've said they haven't time for the consultation, so there isn't going to be time for us. But if we don't take a position today, what in essence will happen?
Again, this is going, in theory, the department could make a decision to go with an LCM. At that point, the LCM will come to the committee. The committee will undertake, the time frames are tight, but it will undertake a level of consultation at that point, and then it'll be down to the committee to draft a report and recommend to the Assembly whether it be approved or not. So I suppose at this point it's not that you're saying yes, definitely this should happen. It's whether we're content for the process of the LCM to start. That doesn't mean that the committee's necessarily going to support the LCM, but we can still ask all these questions in the meantime around who have they written to, what the responses have been, and allow us to do some early work in advance of an LCM that may come.
From my reading of it, this is an issue that is tightening and protecting vulnerable children. So on the whole, I think it's a good thing, given what the clerk has said about us. You know, if we allow the LCM to come forward, there is a bit of time for us to get a bit more detail, and it doesn't tie us to actually accepting the LCM. I would be inclined to allow the committee to come. Danny, you wanted on then, Linda?
Okay. I would absolutely agree with you. I know we don't have time for the full consultation, but this would give us an element of consultation and enable us to sort of hear from those stakeholders, and then when that element of consultation comes in, we can discuss the LCM here. So yeah.
Okay, Linda.
On that basis, Chair, just getting that clarification is I'm content with that, because we're going to get more information. So that's grand.
Okay, is everybody content then with that course of action? Okay, thank you. So 8.16, can I refer members to page 322, and that's an invite from Common Youth, a free and confidential sexual health and wellbeing centre in Belfast. So they've asked if members are content that we add the organisation to our list for informal visits. Danny?
Yeah,
absolutely. I've visited this group in Belfast. The work they do is amazing for young people. Absolutely think. I don't know, is it a request that we visit them, or a request that they come to visit us? It's absolutely, I think we should, if the chair's in agreement. It's wonderful.
Well, I mean, it's the committee. I mean, I would imagine in these circumstances that they would then write and offer a date, and any member that wants to go would go and visit them. Is that not the way forward? Okay, is everybody happy? Okay, thank you. So forward work programme, can I refer members to...
Sorry,
Dan.
can I just ask one question?
Yes.
So there's a letter in on HPV testing and the Belfast Health and Social Care Trust. Last week, I mean, was this in last week, or am I doting? But really the important thing is that we ask the Minister to provide us with that additional documentation. What is that additional documentation that the UK Accreditation Service requested by the 30th of April before they would consider any accreditation of the Belfast Trust for HPV testing? And I suppose then the second question arising out of that, why did the Belfast Trust get the contract for HPV testing, given that it didn't have accreditation, but that the Northern and Western Trust did?
Sure.
Go ahead, Linda.
Or is that, maybe that's an extension of what we asked last week. I can't remember. I may even have written that letter.
It actually sounds similar, Dan. I'm going to bring Linda in. Is it in the same subject, Linda?
It is. Actually, my original hand up was on this before you mentioned the other letter, so apologies for that. My concern is the fact that they're saying we can't give you a time frame.
Yeah.
I understand where Diane's coming from. They've kind of answered that before in committee. The ministers actually, I think, answered a couple of times. So I want to know, I mean, if they're not giving us a time frame, I want them to tell us when it's done. I am just really concerned that we get some way of tracking when this accreditation happens, because I don't want us to be 6 months down the line and thinking, did that accreditation ever happen? What's happening here? Women have been let down time and time again by our health system. And I am determined, particularly on this issue, given what the Southern Trust has been through and all of those women that are involved in what happened in the Southern Trust, that we're never again in that position. Never again in that position. I want to be able to confident and be able to give myself personally, as a woman who's still of an age that regularly has smears, but also my daughter, my sisters, everybody around me, the people I represent, all of the women out there. I want to be able to say, I feel confident that I would be happy. Because if I'm not even happy, then how can I expect all of the women who I represent to be content that they're getting a fully accredited examination in terms of the HPV testing of their smear? Just we can't allow this to run on and never have any clear information on it. That's just really, really worrying for me.
Okay, so in the actions, what we're doing is requesting to be notified following completion. So is there anything above and beyond that we need to go back to them on?
I think the issue around why the Belfast Trust.
What they had a visit. I think it was at the end of January, and at the end of January they were told it was kind of like a work in progress, more to do, and at the same time, to me is inexplicable. The contract went to two trusts. Was taken away from two trusts who had accreditation, given to a trust who hasn't accreditation. And when they're visited by the UK Accreditation Service, they're told that they have more to do. I can't get the logic of that, and I don't understand the logic of that. And the Public Health Agency has never provided a logical explanation for that. And I suppose just to add on to that, I mean, women are now waiting sometimes 12 weeks for the results of smear tests. And I think we should ask about that. Now, I have been told that that's around a verification process between the trust and GPs, and it should be sorted out reasonably soon, but I think that's a valuable and worthwhile question. Like Linda, we want to have confidence in the system that we have, and we want to know why decisions were taken in the way they were, so that we can have that confidence.
So we want information on the process for awarding a contract, how it was done.
Yes.
That issue then of 12 weeks, we want to ask a question
Yes.
in relation to that, and then we want to be notified following completion.
Asked for exactly what is the work in progress that they've asked for. You know, like what exactly, what was the progress report, and what more have they to do?
Linda, does that cover your issues as well?
100%, yeah. Thanks, Chair.
Okay, thank you. Thanks very much.
The letter, Chair, I'm just reading it there, it says the UKAS requested additional documentation. What does that mean? I mean, it's not, they're not raising any queries maybe about the actual performance, but they're wanting extra documentation. It's a bit ambiguous there, just what the issue of the delay is.
Yeah, well, hopefully from the questions that we asked we'll get the answers, or we'll just go back with more questions,
Yes.
which just seemed to be the way of it. Forward work programme. So members, tab 10, draft forward work programme, page 349. Just our committee meeting scheduled for the 8th of May is going to be held in the Fire and Rescue Services Learning and Development Centre in Cookstown. So we're going to have a tour of the facility before the meeting begins. Can I ask, before I go on, the London visit. So at last week's meeting, we agreed that we wouldn't go unless we had a quorum of 5. So I've just checked with the committee staff. So at the minute, there's 3 confirmed. There's 1 no, and then there's no other responses. So deadline of tomorrow lunchtime, just given the Easter recess, to let the committee staff know, and if we don't have 5 confirmed by then, we're going to have to postpone the visit. So as I say, there's 4 people have confirmed either yes or no, and that obviously leaves 5 who haven't. So if we can get confirmation from those 5, yay or nay, and then we can make a decision. But I mean, I don't think there's any point going, or we've agreed there's no point going unless we get at least a quorum. So that's 5. So that's where we're sitting with that. Number 10, any other business? None. Next date and time of meeting is Thursday, 1st of May, 2 p.m. Only thing left for me to do is happy Easter to you all and adjourn the meeting.
Committee Room 29, Sound. Committee Room 29, Sound.